All right, good morning, everybody. Welcome back. We're excited to have you here again this morning. For those online, I know we had a slight technical difficulty this morning, but we're so happy that you're back with us. If you have any challenges online, please, of course, you know Michelle is there at the ready for you to be able to help you. So really, I wanted to just open up a little bit this morning and talk about what we have been doing at HPA. Of course, we shout it loud and proud on our social sites and our website. But I just really wanted to kind of talk about that a little bit, because really our mission is to improve the lives of those impacted by hypopara. Now, that could be a patient, that could be caregivers, that could be your friends and family. So we want to be able to educate and advocate for you and help you do that as well. So we've had a really big year. We've done a lot of things. One of our biggest projects this year was the website. And I don't know how many of you have been on there. I know we use our social sites a lot, but our website has this wealth of information. Somebody had asked me, like, how do you know about clinical trials? How do you know about this? We have it all listed out for you. So spend some time. We update that regularly. Spend some time getting on there and learning about all the different things that we have. And of course, all of this is sponsored through our pharmas, through donations. So we're going to be working really hard to see how we can continue those efforts to continue the work that we do. We've increased our online presence across the board with physicians, with patients, and we will continue that outreach, because we know that we've only touched this many people so far, and we need to touch this many people because we all know how this affects us. So we're going to continue those efforts as well. So again, the website has been our major thing. Michelle and I have gone out and we've done conferences at Endo. We went to ASBMR recently. We had Deb, who went out to Global Genes this year. So we're really trying to expand our where we are, and we set up these wonderful little booths as we go. So we talk to so many physicians to be able to really educate them. It's really interesting as we share with them as patients ourselves the different things, and a lot of them just, you know, maybe it's just take a Tums or something. And of course we're like, yes, we do that. And then we try to educate them a little bit more. But again, it's a rare disease, so we can't expect every physician to know every single thing about a rare disease. So that is our continued mission, is to be able to get out there and spread the news to as many people as we can. Now, we are all patient board, and that's a fabulous thing, because we're passionate about it, because it's our care, it's your care. But again, it could also be we're patients, and we know how hypopara is, and sometimes it's, you know, we work full time and we're doing this as well. So we do need additional help with committee members. We're looking for a board member that can really help us in the Treasury department. So we need somebody that can help take over that part, because as much as she does every single thing in this organization, Michelle, she's a jack of all trades. She takes over whatever we can't get done. So, but we want to get her really focused on her advocacy part. So we do need somebody from a Treasury perspective. We also need somebody on the back end for that has some IT experience that can help us. We've built this amazing website through the pharma's help in building that, but now we need somebody who can help manage that on the back end. So as you're thinking about how you can be the change, we're certainly looking for volunteers, and we would love to talk to you about that. So there's that. And then we've done some really great work this year with RareX with Deb. As you saw, we had the booth out there, and she said we've got some great patients and information. So it's really great to continue to learn. So please, again, this is all on our website, so you can go out there and take a look at what we have there. I participated in a podcast that I'm really excited to come out. I think Dr. Shobak was there, and we had another patient. So that should be coming out, I think, at the beginning of the year, or beginning of the new year. It should be, it's a 3-series podcast that talks about hypopara from a patient perspective and from a doctor perspective. Our biggest news that we have going on, and you've heard us talk about it a little bit, is we were able to actually get granted the PFDD with the FDA. Michelle has done an amazing job at being an advocate for that, going through the process, learning everything that she could learn to be able to go, how do we do this? And she is in major preparations, which I'm going to have her talk a little bit about. But I definitely want to give her kudos for the work that she's done this year. Michelle. All right, so I think that's probably it for me for this morning. I'm going to have Michelle talk to you a little bit later today about the PFDD, a little bit more about the website, and then as we go through the day, if you see us on breaks and you have experience, whether it's with, you know, IT, helping to be a treasurer, whatever that is, please reach out to us and let us know, because we are always welcome to have you on our team. So without further ado, I'm really excited about our next presenter. Dr. Michaela Rubin is the Assistant Professor of Clinical Medicine at Columbia University. She has been a huge supporter of our HPO community for years, and we thank you for all your work, Dr. Rubin.
Good morning, everybody, and it's such a pleasure and so meaningful to be here today and to see many old and dear faces and to meet many new faces as well. So I'm going to talk today with a focus on cognitive function in hypoparathyroidism. These are my disclosures. So I don't need to tell everyone here what hypoparathyroidism is, that it involves low calcium, high phosphate in the blood, and high calcium in the urine in the setting of PTH being absent. And I think we also all know here that it's a very rare disease known as an orphan disease, most commonly caused by an operation done in the front of the neck, but that there are other important genetic and rare causes like autosomal dominant hypocalcemia, which we heard about yesterday, or autoimmune polyendocrine syndrome, which can also happen, as well as other causes. And I think we also know that parathyroid hormone works through three main systems in order to keep calcium and phosphate levels normal. It works at the bone, it works at the kidney, and it works at the intestine. And the overall net effect is to raise calcium levels in the blood, lower phosphate levels in the blood, and keep urine calcium levels down. And our goals in taking care of a patient with hypoparathyroidism, as we know, is to keep the corrected serum calcium in the low normal range. Corrected means when it's adjusted for the amount of albumin or protein in the blood, because it's the part that's not attached to albumin, that free calcium that is active in terms of biological effects. We don't want patients to have symptoms of low calcium. We don't want people to have a high urine calcium. For a woman, that generally means the calcium should be under 250 milligrams over the day, and for a man, under 300 milligrams. We don't want phosphate levels to be high. We think that can set the stage for calcification developing in tissues where it shouldn't be. We want magnesium levels to be normal, because people with hypoparathyroidism sometimes struggle with it, and it can exacerbate a low calcium level. And we want vitamin D, meaning so-called regular, or what we call parent vitamin D, to be in the normal range as we would want for any patient. And this is the conventional management, which everyone here is familiar with, but we use calcium, could be carbonate or citrate. We use calcitriol, which is the activated vitamin D. Always important to know that that has a short half-life. So if you're taking 2 pills, not to take it all at once, but to split it up. We want people to take regular parent vitamin D to have good vitamin D levels, magnesium if needed. Some people are helped by taking a water pill known as a thiazide that can help to block calcium that's lost in the urine and raise calcium that's in the blood. Sometimes we advocate for PTH treatment, and these are the indications based on the guidelines that we heard about yesterday that were published last year. So we would think about recommending PTH treatment if somebody's having symptoms of their low calcium, if somebody's phosphate in their blood is high, if they're having some evidence of kidney damage, if their urine calcium is too high, if their quality of life is poor, which we're going to talk about more in a minute, or if they're not able to absorb calcium and vitamin D from their intestine, then PTH treatment could be very helpful for that person. So I'm focusing now on quality of life because that relates to what I want to really zone in on in this talk. And there are many studies now in hypoparathyroid people that have used questionnaires to assess how the patients feel about their quality of life. And a lot of studies have used general questionnaires, and that means a questionnaire that is very well known but used in other diseases, not only in hypoparathyroidism. And probably the best known questionnaire is something called the Short Form Health Survey, or SF-36. So this has been used with many other conditions, and it has questions that are like, have you felt full of pep? Has your work been affected by your physical or mental health? Are you feeling down? Are you feeling like you're able to accomplish what you want to? And the answers to these questions have been shown to really correlate well with actual quality of life. But this questionnaire isn't targeted specifically for the type of hypoparathyroid symptoms that we know that people with hypoparathyroidism experience. So we now have special questionnaires for hypoparathyroidism that can better capture the very relevant symptoms. And I'll group these into physical, emotional, and cognitive symptoms, and then delve into cognitive a little bit more. So the physical symptoms that I think everybody in the audience knows better than I can describe, but these can include muscle cramps, spasms, and twitching, tingling, pain, being sensitive to heat, feeling very fatigued. Sometimes people also say that they have a rapid heartbeat. And there are other symptoms here that I haven't included as well. But certainly these physical symptoms can be very dramatically debilitating, like a patient who told me she had to get her son to the doctor and had to pull over and not be able to take him because she felt that a calcium crash was coming on. Or, I have a patient who's a conductor and he literally couldn't lift his arms to conduct, or not being able to pick up your children. So again, you know better than me how hard these physical symptoms can be. We're also able, with our disease-specific for hypoparathyroidism questionnaires, to capture emotional symptoms. And depression is a clear-cut part of having hypoparathyroidism. So this can mean feeling sad or blue or low energy. And the biggest study, we called it a systematic review that puts together all of the data on complications of hypoparathyroidism, that was published last year along with the guidelines, showed that looking at almost 19,000 people, that depression was present in 9% of hypoparathyroid people and was one of the most common complications. So I think there's no question that that's part of the disease. And people with hypoparathyroidism, almost all seem to have some degree of anxiety. Among other sources, it was documented in a survey done by the Hypoparathyroidism Association, the Voices of Hypopara, and people gave different reasons for having anxiety, and one was just worrying about the future. Will I be able to take care of myself, my family, continuing to work? What about the long-term consequences like tissue calcification or kidney damage? And I think most disturbingly of all, a lot of patients feel anxious because their doctors might not understand what they're going through, and many times are told nothing is wrong and everything is okay. And I think that could really trigger a lot of anxiety in someone. And I'm going to turn now to the focus of the rest of the talk, which is cognitive symptoms. So I'm not going to do it, but I think if I asked everyone to raise their hands if they've experienced brain fog at some point or another, it would be kind of ubiquitous here in the room. And this is things like somebody saying, I can't remember somebody's name that they just told me 2 seconds ago. I can't remember my last thought. And many patients will say to me, I'm wondering, am I getting early Alzheimer's? Is this normal aging? Is this how it should be? And people will describe that they can't remember like they used to, or concentrate, or find the right word, or understand information, or think clearly, or kind of feel like they're functioning with a veil over their mind. So this is something that people with hypoparathyroidism really describe feeling, and these questionnaires, both that are specific for hypopara and that are general for all diseases, clearly show that people with hypoparathyroidism undoubtedly suffer from this. So one important obvious question is, does being on PTH help people feel that these cognitive symptoms are being alleviated? And we do have some data. In the main NAT-PARA study that led to it being approved back in 2015 that used that general questionnaire, the SF-36, it did show that the people who were on NAT-PARA did have an improvement in how they perceived their cognitive symptoms were, especially in those who started out with the worst cognitive symptoms to begin with, while the people who were on placebo did not report that they felt they had an improvement in their cognitive symptoms. Disappointingly, the change in the NAT-PARA group as compared to the change in the placebo group did not reach what we call statistical significance, which meant that it still fell within the margin of error, and this probably happened for a bunch of different reasons, but nevertheless, within the NAT-PARA group itself, it was shown that feeling that cognitive symptoms were improved was detectable. We have more recent information to tell us about how people feel their cognitive symptoms are while on PTH, and this is data with TransCon. And it showed that being on TransCon, PTH, as opposed to being on placebo, using both that general questionnaire, the SF-36, and a disease-specific hypopara questionnaire called the Hypoparathyroidism Patient Experience Scale, that patients had improvement in multiple areas of quality of life, not just cognitive. So they felt that their physical symptoms improved, like less cramping, twitching, that cognitive symptoms improved, like being able to think and concentrate better, physical functioning, so being able to do more strenuous tasks, and daily life, being able to function better at work or school or go on a trip. So this is certainly very reassuring and compelling data that people feel that their quality of life improves when they're on parathyroid hormone. But what's really lacking in the literature is very little information using objective, standard, quantifiable measures of people's cognitive function. So I think we know very well how people experience it, but we also want to be able to say which specific cognitive domains are affected and which can we actually see in a rigorous scientific formal method are being affected by hypoparathyroidism, and can these specific cognitive domains be improved with parathyroid hormone treatment. So there are a lot of cognitive domains, and this, I'm going to show you some. It's not an exhaustive list, and some of them are overlapping, but I'll try to explain them to you. So one cognitive domain, one category reflects how much knowledge have you accumulated, and this very much relates to somebody's education and culture. But for example, this would include what is somebody's vocabulary. So if someone were to say a word to you, could you identify quickly the right picture that goes with it? What is someone's level of reading? So if someone gives you a word to pronounce, can you read it well? So these reflect the accumulated knowledge that someone's gathered over their life. It's also called crystallized cognition. But then there's the other category, which is the ability to acquire and act on new information. So kind of how quickly can you think in different ways on the spot. Those are called fluid cognition. So one of that would be executive function. So that would be how well you're able to multitask, how well you're able to plan things, kind of your cognitive flexibility, how you can take in new information and recalibrate based on that. Another is finding words, which we know people with hypoparathyroidism often complain of. That's called semantic fluency, but that would be if someone said to you, okay, in 1 minute, name all the animals you can think of. So how quickly you're able to pull those words out. Another is attention. So that means how well you're able to focus on one central thing and not be distracted by different stimuli to the side of you. So basically paying attention. Another cognitive area is processing speed. So that's how quickly you can take in and react to new information. So if someone showed you two pictures and said, tell me as fast as you can, are these identical or are they different? So how fast are you able to take that in information and give the feedback? Another is visual spatial functioning. So that's seeing the relationship between shapes. What this might mean in practicality is looking at a map and being able to figure out easily how to use it. And then there's a whole bunches of category of memory. So one is episodic memory, and that's how well you're able to remember things in the right order. So kind of remembering episodes. So if I said to you, could you tell me in order what you ate last night for dinner, or what was the order of things you did last week in your trip in Paris? So that would be remembering episodes. A different category of memory is working memory, which means how well you're able to remember things and work with it. So that would be if I told you, okay, here's a list of 5 animals. Please tell them all back to me, but in the order of biggest to smallest. So in other words, how well you can remember something and work with it. There's also visual memory. So that would be, let's say you drove by a street on a sign on the road, how well you're able to remember what that sign said. Auditory memory, how well you're able to remember multi-step instructions that are told to you. So again, some of them are overlapping and there are other ones that I didn't mention here, but just to give you an idea of how we could kind of view cognition, in quantifiable, discrete domains. And there's very little studies in hypoparathyroidism looking at cognitive function this way. There's one study in patients with non-surgical hypoparathyroidism, and they actually found that a third had cognitive dysfunction. And they used some tests that showed that there was reduced inhibitory control or a feeling of lack of self-control, impairments in visual spatial functioning, which again would be like looking at a map and figuring it out. They also found some data on motor or movement compromise. And then there's a study in post-surgical hypoparathyroid patients where actually using some of these tests, they didn't find a difference from people without hypoparathyroidism. But what they did see was that people with hypoparathyroidism who had lower calcium levels had worse visual spatial attention. That actually means being able to focus on a specific location. Executive function, again, being able to multitask, plan, and be flexible in your cognition. And semantic memory, which means your long-term accumulated general knowledge. Like if I said to you, what's the capital of Cuba? So this study found that if you had a low calcium, you were more likely to have trouble in those areas. So I'm going to briefly show you some of the new data that we found in our study at Columbia. We call our study SHINE, which stands for the Study of Hypoparathyroidism and Its Natural Evolution. And it really is a natural history study where we're inviting people who have hypoparathyroidism to come and be followed over a few years to be able to learn about the long-term complications of the disease. So I'm going to talk about the cognitive issues, but we're really also looking at kidney function, kidney calcification, vascular function, cardiac function, bone complications, motor function, genetic predictors of developing increased calcification down the line. And at the end, I'll talk a little bit more briefly about that study. But in terms of just the cognitive functioning, what we're doing is a whole bunch of cognitive tests. I'm actually only going to show some of that data here because we haven't analyzed all of it yet, but we've been trained and we work together with a neuropsychologist at Columbia, and the data that I'm going to show you are in 50 participants so far. The mean age is 51, the average age. The participants include 39 women, 10 men, and 1 trans-masculine patient. The demographics are 47 of the patients are white, 2 are Asian, and 1 is Black. The mean duration of hypoparathyroidism is 17 years. 36 of our participants are post-surgical patients, 14 are non-surgical, 23 are on conventional management, which means calcium and calcitriol, and 27 are on PTH, and this is all different forms of PTH. So this is just to show you kind of what the tests look like. Again, there are other cognitive tests, but for the data, I'm going to show you. So one category that's called the crystallized score reflects this accumulated knowledge. And so here we will ask the patient, what's this word? And the patient has to figure out the right picture, so that tests their vocabulary. And then we give a series of words for the patient to read. Some are easy and some are hard, to see how they're able to pronounce it. And so those together comprise this crystallized, or basically accumulated verbal knowledge score. And then the fluid is, again, how quickly you can take in new information and act on it. So for executive function, we'll ask people as fast as they can to match up an object based on either being the same shape or the same color. And it's switched up. So that shows how cognitively flexible someone is. For attention, we'll have one arrow in the middle pointing one way, and then the two side arrows pointing either the same or different directions. And people need to pick out the correct direction of the arrow without being distracted, so that shows attention. Episodic memory, how well you can remember things in order. We give a whole list of activities that somebody does, and then ask the patients to take the activities and order them again the same way they were initially ordered. Working memory, how well you can remember things you're told. We'll give a list of animals and then say, please say all the animals back to me, but going from largest to smallest. And then processing speed, we'll show two pictures and say, tell me as fast as you can. Are they the same or are they different? And we see how quickly people are able to do that correctly. And very importantly, when we get the scores on this, we have to compare each person to somebody who's like them, who doesn't have hypoparathyroidism. So somebody's age, gender, race, ethnicity, and very importantly, their level of educational attainment is going to influence how they score on these tests. So all of the scores that we get are adjusted based on a very big normal reference range to be able to take these factors into account. So I'm going to start with showing you, and again, this is just our preliminary analysis, the crystallized cognition, which again is the accumulated store of verbal knowledge, which comprises reading, vocabulary, and then composite, which is just putting those two, reading and vocabulary, together. So a score of 50 is considered normal in the US population. And you could see in people who are not on parathyroid hormone therapy, who are on conventional measurement, that the scores are actually okay for the reading and vocabulary, and then putting them together. And then when we compare them to the people who are on parathyroid hormone, they're really also okay. The bars might look slightly different, but they were not different enough to reach any statistical difference. So we would say from this preliminary analysis that the accumulated store of verbal knowledge, which really reflects people's education, seems to be intact in people with hypoparathyroidism. On the other hand, when we looked at fluid cognition, the results were a little bit different. So again, the 50 line shows what is expected to be average in the United States. So we could see executive function, or again, cognitive flexibility, being able to multitask and plan and pivot, was lower than the average population in somebody with hypoparathyroidism. Attention, being able to not be distracted, was also lower. Working memory, so that's remembering things and being able to put them in a new order, was a little bit decreased. Episodic memory, maybe barely decreased. That's remembering things like what you ate for dinner last night. Processing speed, maybe a little bit decreased. Again, that's how quickly you can say, is something the same or different, or just the speed with which you can process new information. And taking all of these fluid aspects together, the composite score was lower than the average in the population. And then when we compared these scores to the people in our study who were on parathyroid hormone, we could see that their executive function actually was significantly higher. We also saw that their attention was significantly higher, although not quite reaching, the average US cutoff of 50. Working memory, it looks a little higher, but this was not statistically different. Similarly, the episodic memory really was not different at all. The processing speed being on PTH did improve significantly. And when we take the composite of all these scores of people who are on parathyroid hormone, you could see that the composite of this form of cognition, called fluid cognition, was significantly higher in people who are on parathyroid hormone therapy. So again, this is preliminary, and we have other cognitive data, but it does seem to suggest that in very quantifiable ways, there are certain specific areas of cognition that are compromised in hypoparathyroidism and can be reversed with parathyroid hormone therapy. And I'm just going to spend a few minutes kind of thinking about why do we get cognitive symptoms in hypoparathyroidism and why might PTH help. So the first most obvious thing is, of course, when the calcium is low, we know that the nerve cells become triggered much more easily. The medical term is depolarization. But they have a much lower threshold to get excited, and sometimes they'll even get excited spontaneously because they're so highly sensitive without there being a trigger. So maybe the same way this happens in the muscles where we feel the muscle cramps, it's also happening in the brain. Certainly a seizure is an example in the brain of hyperexcitable neurons, but perhaps this altered neuron sensitivity relates to cognitive function in the brain as well. And this is just to make a comment about how important a calcium sensor would be to prevent cognitive as well as physical symptoms, because if somebody could know their real-time calcium level at home, of course, that could ward off cognitive and physical symptoms in a calcium crash and prevent this disconnect where you go to the lab, get a calcium that's just like one random snapshot in time, but it's not, of course, capturing the fluctuations during the day. And I know we're going to hear today a whole talk about having an at-home calcium sensor. Another theory why people might get cognitive symptoms is maybe there's calcium building up in the brain. It is known that calcium can accumulate in the brain, especially in people who have non-surgical hypoparathyroidism. It's known to accumulate particularly in a spot of the brain called the basal ganglia, which relates to movement, like that's an area that might be affected in Parkinson's disease. It's not known to relate to cognition. But in our SHINE study at Columbia, we are finding that there's calcification in other areas of the brain as well. And we don't know, but one of the things we're questioning is whether calcification in the brain can relate to some of the measures of cognitive dysfunction that we're finding. It's also important to kind of think for a minute, why can cognitive function be so different in people with hypoparathyroidism? I know I have patients who are really fine and able to be in sports and have high professional success, but then of course there are people who are utterly debilitated by their cognitive symptoms. Different thoughts about it. It might just be some demographic differences. Many of our studies include perimenopausal white women who are post-surgical. That is the majority of people with the disease, but I think having more diverse populations in our disease might shed some light on the variability of cognitive symptoms. I think education level might contribute. It makes sense if somebody's more health literate, they might be able to better mobilize support and resources to help their cognitive symptoms. And then maybe, I don't know, but if you've had the disease for longer, maybe you've been better able to develop coping strategies and maybe your regimen is more stable. I do know the first year of post-surgical hypoparathyroidism is typically the worst year in terms of cognitive symptoms. And then there might be things kind of separate, not directly related to parathyroid hormone. If somebody has hypothyroidism, we know they can have poor concentration and decreased memory, and I think Dr. Schobach is going to talk about how to tease that out today. But I think a lot of studies do show that over and above the hypothyroid symptoms, hypoparathyroid symptoms have an additional cognitive burden. If someone's depressed, that's a known thing that can impair cognitive function. Some medications can have cognitive effects. If someone is going through perimenopause, that's a well-known time of life where people can have forgetfulness, difficulties with word retrieval, and brain fog. So that might be something that's added to the mix. And then if someone has vascular risk factors, so if their cholesterol is high, which can happen with hypothyroidism, if they're not exercising enough because they're worried about hypocalcemia, or if they just have calcification building up in their vasculature, that could affect cognitive function too. And then maybe PTH itself, not calcium, is playing a role on cognition. We know that there's PTH in the fluid that bathes the brain called the cerebrospinal fluid, and we also know that there are receptors in the brain for PTH in areas in the brain that are related to cognitive function. So this totally needs to be tested. We really don't have any data about this, but it's kind of a speculation. And this is supported because we know in primary hyperparathyroidism, the opposite condition, when people have too much PTH, those patients also have cognitive symptoms. So it may very well be what we can say is a U-shaped curve, that people who have very low PTH levels, like in hypoparathyroidism, are going to have high cognitive symptoms. And people who have too much PTH levels are also going to have high cognitive symptoms. But really, cognitive symptoms are going to be the least likely to be present when PTH levels are at a normal range. And then kind of the last speculation is that maybe we need PTH to promote good blood flow to the brain. It's known that PTH has some effects to dilate blood vessels. It's not a very strong effect, but it is a reason where we might counsel people after taking a PTH shot, could they feel a little bit lightheaded? Sometimes it might be a reason if someone gets some redness if they've done a PTH shot, because there could be some dilation of the blood vessels in that very spot. So again, another theory, but maybe having PTH in the brain is helping better blood flow from some slight increased dilation going on in the blood vessels there. So to manage cognitive symptoms, so this is for practical living life, it's so important to be aware of triggers and know the preceding symptoms. Many people will start to develop both cognitive and physical symptoms when they exercise. So some patients will take calcium right before. Some patients will have their calcium with them right after. So that's a way you could prevent that from happening. I think almost any type of illness can trigger a spiral of hypocalcemia, so you should have a very low threshold if you're sick to be aware of that and consider taking extra calcium. It's well established that having your period leads to low calcium, and this is because estrogen lowers calcium levels. So many patients know that in advance and will take extra calcium at that time. And people have told me that hot weather can just set off their hypocalcemic symptoms. I'm not sure what the mechanism for that is, but that's something that I've heard. So I hope everyone here already knows this, but you should always have calcium and or calcitriol with you and be prepared. And then I'm just going to conclude with telling you just a tiny bit more about the SHINE Columbia Natural History Study. So we want to learn about the long-term complications, how they affect different organ systems in the body. So we do scanning to look for calcification. We look for new predictors in the blood and the urine that can predict the development of complications, tell us who's more likely to progress with their complications, and also to see, are people on parathyroid hormone able to have a halt or even a reversal in some of these complications over time. And it's one visit per year at Columbia. Multiple tests that we do with questionnaires, blood, imaging, cardiac exam, the cognitive that you heard about, motor tests, looking at bone, brain, kidney, blood vessels. That's kind of a brief summary. If you're 18 years or older, you're eligible. Any type of hypoparathyroidism, whether you're on conventional management with calcium and calcitriol, or really any type of PTH, you're eligible to come to participate. And if you're interested, this is my email, and this is the email of our research coordinator, Joanna. So I have to conclude by thanking our participants, many of whom are here today, but it really takes a great deal of generosity to give of yourself to be in a study. Of course, hopefully it's helpful to the participant, but it's really helping other people in the hypoparathyroidism community to fill very big knowledge gaps that we have about this disease. So I'm so grateful for the givingness that everyone has to come and do research for this study and other studies that I've been involved in over the years. And I just want to acknowledge our funding for the SHINE study in particular from the FDA Office of Orphan Products. And with that, I'm going to conclude. Thank
All
you.
right. Thank you, Dr. Rubin. All right. We have just a couple minutes for questions. If anybody has any questions, here we go.
Hi, Dr. Rubin. Are you going to be looking at, when you kind of seem to have clumped the PTH all together, right? So, but there's a big difference between taking Forteo and either Natpara or Transcon. Are you going to be separating those out at any point?
Yeah, that's a great question because I do think cognitive symptoms can vary. It depends on our numbers, you know. Our goal is to enroll 94 patients, so right now we're at 54. So if we have enough numbers that it would be able to show valid statistical significance, then we would like to split it out, but yeah, if not, we'll have to keep it lumped.
As you know, I have non-surgical hypopara, and I think back in 2015, I was diagnosed actually with dementia related to the hypopara. My question is, do you know what the difference, say, between the dementia related to hypopara compared to other types? Would it look similar or different based on how well I do with the, you know, with the calcium levels, or say if I end up going on a Transcon? Do you know, would that change? Would that look different compared to other types of dementia?
Yeah, that's such a smart question, and a lot of patients do ask me that and say, well, if I went on PTH, could I then tease out, you know, how much has gotten better versus how much is because of something else? So I think we don't really know. You know, I think these data are starting to show us that there might be a certain profile of cognitive symptoms that are particularly affected in people with hypoparathyroidism. So maybe if we knew what your symptoms were in particular, we could try to guess, you know, is it likely to be due to the hypoparathyroidism and not something else? And of course, trying to address any other causes that you might have that could be addressable, like, you know, low thyroid or, you know, other imaging or blood tests that could help to try to figure that out. So I can't say for sure that we would be able to tell you, yes, you know, this is definitely because of the hypopara. I think it's tricky, but maybe we'd be able to kind of have some educated guesses on putting a lot of the data together.
I don't think he any other type, but I'm curious how different, you know, just from the other types, you know, like how that would look, because there's no information really, you know, too much currently.
Yeah, no, I think that's something that we need more information, and I think that would be a goal, because a lot of people say that, like, is this the hypopara? Is it me getting old, you know? So I think being able to know how much of it you could blame on the hypopara would be very helpful.
Okay, somebody, Bob? Oh, go ahead.
Have you considered looking at intersectionality of neurodivergence and hypopara with the cognitive functioning?
Explain to me more what you mean by that.
Well, so with neurodivergence, there's a lot of mental load with managing masking and living in a neurotypical world. So is that something, are you looking at those factors as well and considering that with your study?
I guess we haven't thought of it that way, but that would be a great idea. I do think some of the cognitive domains, like attention and executive function, might be more prominent in individuals who are neurodiverse. But I think that would be something great to focus on, because we certainly do have participants who struggle with some of those issues. So I think figuring out kind of the Venn diagram and how they overlap is important. So thank you for suggesting that.
Sure.
We have an online question that asks, does any alternative therapies help to promote the cognitive symptoms, or are there any brain exercises we can do?
That's a great question. Yeah, so in the neuropsychology world, there are different exercises that are thought to be used to promote memory, as well as tools that can help people fill in some of these deficits. So I do have a little bit information on that, if you would want to email me, as I've looked into it a little bit. And then I think also, re- a little bit of a tangent, but modifying anything else that could indirectly affect cognitive function. Like we think maybe optimizing your cholesterol in case that's contributing to vascular cognitive dysfunction, could be helpful as well. But yes, there are strategies, in the neuropsychology world for cognitive promoting exercises.
There's another question that asks for some clarification on when you talked about estrogen helping with calcium levels, because they believe that they had heard in another presentation that it could actually lower your calcium level.
Yeah, I must have misspoken because that questioner is correct. Estrogen lowers calcium levels by about 0.5. So I apologize. And that's why when women are menstruating, their calcium level can very well drop. So that's correct. Thank you for clarifying that.
My question was, when you guys are doing these cognitive function tests, are you checking people's calcium before they take the test? And are you guys checking their cognitive function during a calcium crash, like before, during, and after? And how does that compare?
Great question. So we do collect the calcium right before the cognitive test. So we haven't looked at it, but we should be able to analyze whether the actual calcium level is impacting certain parts of the cognitive function. We haven't been able to do it during a calcium crash, I guess, because when people are coming to the visit, unless we were to elicit a crash, I don't know how we would be able to capture that. If someone has suggestions, because I think that would be, important and useful information.
All right, well, thank you, Dr. Rubin. What a great presentation. Let's give it up for Dr. Rubin. Okay, we have about 5 minutes till our next presenter comes on, so we'll see you in 5.
Welcome back, everybody. That 5 minutes goes by super duper fast. Okay, so moving on to our next presenter. Before we do that, I want to make a little quick housekeeping announcement, is that please make sure to visit our photo booth right around the corner when we have breaks later today. They have some really cool things that you can take pictures, and we want to get all the pictures that we can. So make sure to do that. But our next presenter is Dr. Mary Scott. She's a pediatric endo and executive director of clinical development at Calcilytics. So we're very excited to have her on board and speak to us a little bit today about Calcilytics. Welcome.
All right, good morning. Thank you all so much for the invitation to join you. A few of my colleagues and I are thrilled to be here with you this weekend. And I'd like to spend a bit of time today going through the different genetic causes of hypoparathyroidism, and then I want to talk to you about the development program that we're working on at Calcilytics for patients with autosomal dominant hypocalcemia type 1, which I'll refer to as ADH1 because that's a mouthful, towards the end of my talk. Okay, and a disclaimer before we get going, I will be talking about encaleret, which is an investigational drug, and it does not have health authority approval yet. And then who we are at Calcilytics. So you're probably wondering, why is there a name of another company up there? But Calcilytics is a sub-company or an affiliate of a parent pharmaceutical company called BridgeBio. And our mission is to discover, test, and deliver medications to treat patients who have genetic diseases or have cancers that are caused by genetic diseases or genetic changes. And one of those genetic diseases, as you've probably already guessed, is ADH1. Now, I know the people in this room probably know hypoparathyroidism better than anyone, but what you may not spend a lot of time thinking about are the underlying causes of hypoparathyroidism, with the exception of why you personally have this disorder. And so by far, we know the most common causes of hypoparathyroidism are post-surgical. So of all patients that have hypoparathyroidism, 70 to 80% of them are caused by post-surgical. The remaining three categories require a bit more detective work by your physician to figure out which one you might fall into. There are genetic causes, which make up roughly 10 to 12.5% of cases. There are autoimmune causes, which we think make up less than 10%. And then the other category are idiopathic or unknown causes of hypoparathyroidism. And as Dr. Schobach talked to us about yesterday, this is often when your physician has performed all of the testing to try to figure out why you have hypoparathyroidism and nothing comes back on the lab results. And I would note that part of that workup in my mind includes genetic testing, because I've met a number of patients who have been given the diagnosis of idiopathic hypoparathyroidism, but they'd never had genetic testing, and then once that was performed, they were able to figure out the underlying cause. So now we'll do a bit of a deeper dive into genetic causes of hypoparathyroidism. And I divide these into three different buckets. There are disorders that affect how the parathyroid gland forms. So when a baby is developing in their mother's womb, this genetic change occurs and the parathyroids don't develop normally. There are also disorders that impact PTH secretion. So patients have parathyroid glands. They're just either not able to make PTH or they're not able to secrete PTH. And then the final category are genetic changes that result in damage to the parathyroid glands. In this table and the one on the next slide, I have included all of the causes of genetic forms of hypoparathyroidism. And don't worry, I'm not going to talk about all of these, but I did just want to give you the information that as of today, we're aware of 26 different genes that when they have a change could cause genetic hypoparathyroidism. And so in these tables, you can see the specific gene on the far left column, the name of the condition that it causes in the middle, and then on the right-hand side is the inheritance pattern. And we'll talk about that in just a bit in more detail, but what I want you to note is that there are different inheritance patterns or how this disorder could pass through families based on the gene that's impacted. So these are the disorders that affect parathyroid gland formation. And one of the other things that I wanted to note is that some of these are part of a syndrome. So when we talk about a syndrome in medicine, it means that typically there are multiple different medical findings that can occur in a given syndrome. So you might have hypoparathyroidism, you might have heart structural changes, you might have immune system changes, and so some of them only affect the parathyroid glands as far as we know, and then there are others that can affect other parts of our body. And then this is the second table that includes the disorders of parathyroid hormone secretion. You'll see that ADH1 is listed here, and then the final category is the damage to the parathyroid glands, and that includes the autoimmune polyendocrinopathy syndrome that Dr. Leonakis spoke to us about yesterday. Okay, so to talk a little bit about the inheritance patterns, when your physician is seeing you and thinking about, do you have a genetic form of hypoparathyroidism, and then thinking about all of those 26 genes that they have to consider, one of the clues that can kind of point them in the right direction is the pattern of inheritance through a family. And so I thought we could walk through a couple of examples here. On the left-hand side of the screen is an example of autosomal recessive inheritance. Autosomal means that the gene is not on a sex chromosome, and recessive means that you need 2 copies of that abnormal gene variant to have the underlying medical condition. So in this example, the father, you can see his chromosome pairs that contain the genes, and he has 1 abnormal gene in green, 1 normal gene in purple, and he's what we call an unaffected genetic carrier. So he has 1 abnormal copy, but he doesn't have the medical condition because he needs 2. And then the mother has exactly the same condition. So what happens when these 2 people have children? And so then you see the kids on the bottom here, and we typically get 1 copy of each chromosome from our parents. And so if we do the different ways that we could divide them up, they could have 1 kid that would have 2 normal copies. They could have 2 kids that would have 1 normal, 1 abnormal, so the unaffected carrier, and then 1 child that would get 2 copies of the abnormal gene, and that kid in the turquoise would have the underlying medical condition. So if we do the math, there's a 25% chance that a person with an autosomal recessive condition would have a child that would also have that condition. On the right-hand side of this screen is an example of autosomal dominant inheritance. Dominant means that you only need 1 abnormal copy of the gene. And you can see that in this situation, there's a 50% chance that a patient that has an autosomal dominant condition would have a child that also had that condition. And then the final example is an X-linked recessive inheritance. This one is a little bit trickier because it involves the sex chromosomes. So typically women have 2 X chromosomes and men have 1 X and 1 Y. And if the father has an abnormal copy of the gene on his X chromosome, he could have a daughter that's unaffected, an unaffected carrier, and then the son would be unaffected. But on the right-hand side of the screen, if you have a mother who's a carrier on the X chromosome and you have a father who's unaffected, there's a 50% chance that a son from these parents would have the condition, because with X-linked recessive, you just need 1 copy on the X chromosome if you're a man, because you only have 1 X chromosome, and then half of their daughters would be carriers. So if you have non-surgical hypoparathyroidism, why should you consider genetic testing? And my personal opinion is that knowledge is power, and it gives you information about why you have an underlying genetic condition. And this can help with understanding how to best manage you as a patient. If you're a patient with ADH1, for example, you might have a higher risk of high urine calcium than other forms of hypoparathyroidism, so your doctor may want to check your urine calcium more frequently and pay closer attention to where those levels are ranging. It also can help inform members of your family that also might carry the genetic variant. It can assist in family planning. And then importantly, I think it helps you to make informed decisions regarding potential participation in clinical trials. And you all probably know that there are some of the studies that are ongoing now that only enroll post-surgical patients, some that only enroll genetic patients, and some that enroll both. So because we think that there is value in performing genetic testing in patients with non-surgical hypoparathyroidism, at Calcilytics, we've partnered with a genetic testing company called Prevention Genetics to create this Detect Hypopara genetic testing program. And what this program does is provides no charge genetic testing for patients in the US and Canada. And so if you wanted to think about taking part in this program, you could do so if you have a diagnosis of non-surgical or idiopathic hypoparathyroidism, you have a diagnosis of low calcium that's thought to be due to a genetic cause, or if you have a relative who has a diagnosis of genetic hypoparathyroidism. And you can see all the genes that are included in this testing panel, which are the full 26 genes that we reviewed earlier on those tables that I showed you. And these are preliminary data from the sponsored genetic testing program. And Dr. Monstad actually presented this earlier this year at the Endocrine Society meeting. And this is as of March of 2023. We had 181 patients submit samples for the testing. The average age of these patients was 24.7 years, and the majority of the patients that were tested had a diagnosis of non-surgical or idiopathic hypoparathyroidism. And then you can see in the bar graph on the right-hand side of all of the patients that were tested, around 40% of them were found to have a variant that suggested that it was the cause of their underlying hypoparathyroidism. And of those 40% that had a variant, over 50% were found to have a variant in the calcium sensing receptor gene, which you learned yesterday is the cause of patients with ADH1. And so this data suggests and kind of supports what we've thought, at least in the medical literature in the past, that ADH1 may be the most common cause of non-surgical hypoparathyroidism that's not associated with one of those syndromes. And so because of that, we are working on a potential treatment for patients with ADH1 at Calcilytics. And I know that you all covered this yesterday in quite a bit of detail, but I just want to remind you that patients with ADH1 have oversensitive calcium sensing receptors. So that means that the calcium sensing receptor tricks the parathyroid glands and the kidneys into thinking that the blood calcium level is in the normal range, but instead it's quite low. And so when you look at the labs of these patients, they have low PTH, they have low calcium, and then they often have increased urine calcium. And so when they present, their symptoms are related to hypocalcemia, so they're the things that you all are well aware of, and some of you, I'm certain, have experienced. And when we look at the graph in the bottom right, around over 70% of patients do present with some symptoms that could range from mild to severe. And this is from the study that Dr. Roscoe presented to you yesterday. So our current treatment options for patients with ADH1 include calcium and activated vitamin D. This, of course, does not address the underlying cause of hypoparathyroidism in this patient population, and it has the potential to worsen or induce increase in urine calcium. And you can see an example of that in the graphs on the right-hand side of the slide. These were produced from one of the very first papers that described patients with ADH1, and the gray bars are baseline lab values that were before the patient started treatment, and then the green bars are lab values on treatment, and that's with calcium and then some form of vitamin D. So you can see in the upper left that the serum calcium was quite low at baseline. And then with treatment, they were able to increase the blood calcium. But the problem that we see is the next graph over, where the urine calcium also increases on treatment. And we know that this places patients at an increased risk for the long-term complications associated with ADH1, which includes calcium deposits in the kidney, kidney stones, and both of these place patients at an increased risk for developing chronic kidney disease. So with that in mind, at Calcilytics, we are working on a medication called encaleret, which could be a potential treatment for patients with ADH1. And this drug is an investigational oral calcilytic. That's a bit of a mouthful. Investigational means that it has not received regulatory approval. Oral, it's a pill, so you can take it by mouth. And then calcilytic is the class of drugs that this compound is in. And as you learned yesterday from Dr. Gaffney, calcilytics decrease the receptor's sensitivity to extracellular calcium. And you all know that patients with ADH1 have oversensitive calcium sensing receptors. So if the drug can bind to those abnormal receptors, normalize the sensitivity to the extracellular calcium, then we might see a correction in the low PTH, the low blood calcium, and the high urine calcium that these individuals have. And that's exactly what we're trying to do with the clinical studies that we're running at Calcilytics. And so you learned about our phase 2 study yesterday, and I did want to take a minute in case you're not as familiar with clinical trials, but a phase 2 study is typically the first study that is conducted in patients with the underlying medical condition that the drug is intended to treat. And usually the goals of phase 2 studies are to, 1, make sure the drug is safe, and 2, understand what doses might be needed for patients with the medical condition. So that's exactly what we were trying to do with this study, in which 13 patients with ADH1 were enrolled at the NIH Clinical Center. And as Dr. Gaffney walked us through yesterday, she was able to demonstrate that on encaleret treatment, these patients had increases in their blood calcium, their PTH secretion, their 24-hour urine calcium decreased into the normal range, and we also saw that the blood phosphate, magnesium, and 1,25-dihydroxyvitamin D normalized in these patients on treatment. Importantly, encaleret was well tolerated by these patients, and they've been on treatment for over 18 months now, and there were no serious adverse events reported in the study. So with this, exciting data from the phase 2 study, we were very excited and are very excited to move forward with our phase 3 study, which is called the Calibrate study. And so as a reminder, phase 3 studies are intended to compare your study drug and how safe it is, how effective it is, compared to the standard treatment for a given condition. And so that's exactly what we're trying to do here. This is an open label study, so that means that the patient and their physicians know what treatment that they're on for the entire length of the study. And we are trying to enroll 60 patients with ADH1. So there's a screening period where we make sure that patients meet the eligibility criteria. Some patients need adjustments in their standard of care dosing. Then they go into a period that's 4 weeks long, and we try to keep their standard of care doses stable. After that, they can be randomized to either the encaleret treatment arm or they would continue on standard of care. And randomized means that you're selected by chance to go into one of these two treatment arms. And for the case of this study, 2 out of 3 patients would go into the encaleret arm. So it's a 2-to-1 randomization. There's a 20-week period where we're adjusting the doses as needed to try to normalize the blood calcium. And then there's a 4-week period where we hope to keep the doses stable, no changes, and collect data on a steady dose. After the main part of the study, people can continue on treatment if they choose to. And those patients that were in the standard of care arm can start treatment with encaleret for the first time. The main goal of our study, which we call the primary endpoint, is to understand the number of patients on each treatment that can obtain a blood calcium within the target range and a 24-hour urine calcium that's normal, and that's on labs close to the same time. It's kind of hard with the 24-hour urine. And then we're also collecting other data, which you can see in the bottom right-hand side of the screen, includes labs and safety parameters. So these are the main eligibility criteria for the study. Patients need to be at least 16 years of age, and the lower cutoff is 18 years in Europe. They need to have a documented genetic change in the calcium sensing receptor on a genetic testing, either historically or one can be done at the beginning of the screening period, and then a history of a low blood calcium and PTH. They also need to have a documented history of signs or symptoms of ADH1. So if a patient is completely asymptomatic, they would not be eligible for the study. And then from an exclusion criteria perspective, patients need to be off of PTH treatment for 2 months prior to the study. If they've had a history of thyroid or parathyroid surgery, they would not be eligible. Pregnant, nursing women are not eligible. And if their GFR is less than 30, they also would not be eligible for the study. And this is a map of all of our study sites. And so you can see every time there's the little study emblem, that's a location of a study site. So we have a number of site locations in the United States, 1 in Canada, 1 in Brazil, a number in Europe, a few in Asia, as well as Australia. And you'll probably notice some familiar names on the bottom of the screen for the investigators, as many of them have actually been here with us this weekend. Another study that I wanted to tell you about is the Clarify study. So this is an observational trial, which means there's no study drug, and we are enrolling patients with both ADH1 and ADH2, which is another separate cause of genetic hypoparathyroidism. And our goal here is to learn more about the natural history of these conditions. And as Dr. Roscoe talked to us about yesterday, in rare diseases, it's really difficult to understand just what happens with a patient that has this disease because there are such few numbers of people that we can learn from. And what we do know is based on publications in the medical literature that often include 1 family or 2 patients. And when we have those publications, they're often not doing the same testing or the same treatment. So it's really hard to compare and to know. And so for this study, we are aiming to enroll up to 100 patients. And I will say that we originally planned to enroll 60, and then we had such interest with both physicians and patients that we've recently increased that number, which is very exciting. And our goal is to follow them over a 5-year period and to collect the exact same information on every patient over the course of the study. And that includes medical history, symptoms, labs, both blood and urine, looking at renal or kidney imaging, DEXA scans like we learned about yesterday, and then there's an option for head, like brain and skull imaging as well. And we're very, excited to start to get this data, learn more, and be able to share it with you and the community as well. And these are the study sites for the Clarify study, again, throughout the world. And there's an active list of these sites on clinicaltrials.gov. So this is just a summary of the exciting work we've been doing with Encaloret over the past few years. And this year alone, we're enrolling in that Clarify study, the phase 3 Calibrate study, and we've also started a proof of concept study in patients with post-surgical hypoparathyroidism that Dr. Roscoe shared with us yesterday. And then we're also very excited looking to the future. And I think I'm a pediatric endocrinologist. I'm thrilled that we're starting a study in children with ADH1 next year. So to conclude, the biggest points from our discussion today is that 10 to 12.5% of patients have a genetic cause of hypoparathyroidism. And genetic testing in patients with non-surgical hypoparathyroidism can aid in diagnosis, it can improve the understanding by you and your physician, and it can direct your management as well. ADH1 is emerging as the most common form of genetic hypoparathyroidism not associated with a syndrome. The standard of care for these patients is inadequate, and it can cause increased risk of kidney injury. And Encaloret is currently being studied as a potential treatment for these patients by targeting the underlying genetic change that's causing ADH1. We've seen thus far that the drug has been able to increase PTH and blood calcium levels, decrease urine calcium at the same time, and it's been well tolerated with no serious safety issues reported. And then finally, we are continuing to study the medication in a larger number of patients across the world in our Calibrate study. And then I'll leave you with this, and I feel like it might be preaching to the choir a bit, but I would just urge you all to stay connected and to stay informed with what is going on in the hypoparathyroidism community. And you've learned, you're here, so I know you are, but ways that you can do that besides coming to the meeting every year is to check out clinicaltrials.gov and do the search that Dr. Warren talked to us about yesterday. Talk to your healthcare providers. Ask them about research studies that are ongoing that you might be interested in. And then if you have any questions specifically about the information that I presented today, you can email us at medinfo@bridgebio.com, but I'm more than happy to take your questions now or, at a break as well.
All right, thank you. Let's give it up for Dr. Scott, Mary Scott. All right, so who has questions in the room? Okay. Deb?
Just to clarify on the Clarify study, it's for 0 age all through 90?
Yes.
So
great
we can
question.
have the children enrolled in this?
Exactly, yes. We're all comers.
Perfect.
All right, very good. Anybody else? Michelle?
I have lots of online questions coming in. First, since we just talked about the Clarify study, someone said, is there travel support for the Clarify study?
There is.
Okay. Next, can you explain how ADH1 and ADH2 are different? Is it the signaling that's also messed up?
Yes, that's a great question. So as we talked about, ADH1 is a genetic change in the calcium sensing receptor, and then ADH2 is a genetic change in the protein, the G protein, that this receptor signals through. And so often, and Dr. Monstad described this, that often the presentation of patients is similar, but it's different specific genetic change, but in the same signaling pathway. So the question asker was right on track.
Okay. How many patients are you anticipating taking part in the international study for Encaloret?
So for the phase 3 interventional study, we're hoping to enroll 60 patients. And then for the Clarify observational study, we're looking to enroll 100 patients.
Okay. And then, could there also be a genetic component in a post-surgical patient who had hypercalciuria for decades before having surgery?
That's a very good question, and I've heard it before, and not only with the hypercalciuria, but if a patient had hypocalcemia documented on labs prior to surgery, there is a possibility. I mean, there are forms of hypercalciuria specifically called idiopathic, so you guys know that means we don't know why, that someone has it. And that's not that uncommon, so it could be because you could have hypercalciuria long before your surgery because of idiopathic reasons we don't understand. But it could be a genetic change. And so I think, the fact that genetic testing is, well, for us in the US, it's available at no cost and it's pretty quick, and you don't have to fight insurance companies anymore to get it approved, that it wouldn't hurt to do the testing. But I think it's probably one of the more common reasons we see it.
This question kind of goes along the same line, and you might have sort of just answered it, but it says, is it possible to have genetic hypopara if I was just diagnosed at 50 years old?
Yeah, it definitely is. So I think, from my own personal experience seeing patients that there have historically, as I just mentioned, it's been hard to get genetic testing. It's been expensive. You have to fight the insurance company. Some people, are worried that there could be other implications if they had a positive genetic test. And so for, I think a long time, physicians weren't readily checking the genetic testing. And that's why this diagnosis of idiopathic is heard a lot with people that have hypopara. I'd also say that if you have a milder form where you didn't present as a baby with seizures, or you don't have some of the syndromic features, that you could most definitely make it into adulthood without ever being diagnosed with the genetic form. And in fact, with ADH1 specifically, I've seen a number of parents who we diagnosed their child, and then we said, well, we should check your calcium level and the dad's calcium level. And one of them was affected, and they had no idea.
Wow. Follow-up to that question is, do patients with ADH1 and ADH2 tend to stay at similar symptom levels or calcium levels as when they are first diagnosed, or do their calcium levels fluctuate as life progresses and drop to be more serious?
Yes, unfortunately, the calcium levels do fluctuate. And as you all know, and we've talked about a lot these past couple of days, depending on your activity level, your diet, your health, there can be quite a bit of fluctuation in the blood calcium levels. But one of I think the challenges with ADH1, and there may be other genetic forms that I personally just haven't seen, is that there can be fluctuations in the blood calcium that just aren't explained, where the patient was doing fine, and then all of a sudden they weren't feeling well, and their calcium level had dropped without an explanation. So it is one of the challenges in trying to treat patients with ADH1.
And then I have one last question on here. Would a predisposition to autoimmune diseases show up in genetic testing?
So for the panels, the ones that I listed in my presentation, there is only one gene that has been identified to cause autoimmune hypoparathyroidism. So that is a possibility, but then there are many other genetic predispositions for autoimmune diseases, so I'm not knowledgeable enough to speak about what that looks like, but I can say as far as the genetic testing panel that I presented to you, there is the AIR gene that has been associated. And one thing that actually I'll note about that, just for your information, is when I learned about the AIR gene, I was taught that people usually have symptoms pretty early in life, in childhood, 5 or so, they have these candidal or yeast infections, and then around 10 they can become hypopara, and then things progress from there. But in our genetic testing program, we've actually, I think 11% of those 40 that had a variant that was identified had variants in the AIR gene. So I would have thought that they would have already known that, but it was detected at least in the testing program.
All right. Well, thank you so much, Dr. Scott,
thank
for
you.
everything. All right. So before we take a little short break, we do have a photographer that's going to take a picture of all of us. So if everybody could just move straight up front, that would be fantastic. And we'll get that picture done, and then you can take a break. Okay?
Welcome back from break, everybody. Here we go. We're off to our next presenter. Our next presenter is Dr. Michael Manstad. He's the chief of the Endocrine Unit at Mass General, an associate professor in medicine at Harvard Medical School, both in Boston. So we all know and love Dr. Manstad.
Thank you very much. It feels like my fan club is here. That's great. So first of all, let me congratulate you on this amazing meeting, amazing discussions. It's always humbling how much you can learn about the disease you think you know. And it's also technically, it works fantastic. It's well done by everybody involved here. So you might wonder why an endocrinologist speaks about the kidneys, right? You have heard a lot already, and it's also on purpose. It's good to have facts shown to you from different angles. So you've heard already a lot about kidney health, but because it's so important for hypoparathyroidism, I want to give you my view on it. So the next slide will show you my disclosures. Doesn't want to. Oh, now it goes too fast. Wow. If I can get the second slide, that would be great. And yeah, and now the next, let me actually click on this. Yeah, okay, perfect. So you see the two kidneys, right and left kidney, that do all the work, that are exposed and clear the blood that comes through every minute in huge amounts. And then it filters everything out and is left with just a tiny amount that goes through the ureter down to the bladder. It's stored there and then discharged out. And that's what the kidney is doing. What is hypoparathyroidism a risk for? Well, there are at least three different things. One is kidney stones, one is nephrocalcinosis, and we talk more about it, and impaired kidney function. So we all love the parathyroids, right? But we have to acknowledge that the kidneys are a close second. It's a miracle organ. You see on the left side how it looks from an anatomical point of view. You see that the renal artery in red comes in, and then in blue the vein comes out, and in between is really a miracle what the kidneys are doing. On the bottom you see some of the functions: removing waste products, regulating fluid balance. So whether you drink or you don't, the kidneys get the signal from the brain how the water balance is like, and decides whether to hold the water or not. It balances electrolytes like phosphate, magnesium, calcium, and is responsible for the acid-base balance. It produces hormones. It's an endocrine organ. Why the parathyroids produce, as we know, just PTH. Here it produces hormones that are important for the blood pressure control. It's the renin, angiotensin, aldosterone system that some of you might know. It is the site of the main production of 1,25-hydroxyvitamin D, what many of you take as calcitriol. It originally comes from the kidneys, and that's mainly responsible for the circulating active vitamin D. And it produces a hormone for the production of red blood cells. So highest respect to the kidneys. On the right side, you see how a nephron looks like. It's kind of a pipe-like structure, but it's really complicated. There are many different cells and cell types that are responsible for doing the work. And this is an example here. It's small, so you don't have to see and read all the little words here. But on the left side, you see the so-called proximal part of the kidneys, responsible for phosphate reabsorption under the control of PTH. So PTH tells the kidneys to lose phosphate, and if you don't have PTH, you cannot lose the phosphate, and you have high phosphate in the blood. And then calcium is reabsorbed all the way along. On the right side is the main action of the fine-tuning of the calcium excretion, and that is under the control of PTH. So without PTH, it's not that you lose all the calcium. you lose the fine control at the end, right? Otherwise, you would end up with 10 grams or something of calcium. And what is hypercalciuria? Is too much calcium in the urine. And nobody can really feel how much calcium is in your urine or see. And so, but it's a risk factor for developing kidney stones. So the only way to really know how much calcium is in the urine is by collecting a 24-hour urine collection. And so many of you know, but are there any, actually let me first show hands who has collected a 24-hour urine. Excellent. Who has collected one this year? Oh, I like to see that. Who has not collected one in the last 2 or 3 years and has hypoparathyroidism? Yep, okay, thank you for being honest. It's one thing if you don't look at it, you won't see it, right? That's why my mother never goes to a doctor. It's good you listen to this talk. Now, you have heard a lot about these magic numbers, 250 milligrams per day as the maximum for women and 300 for men, and we use it, I use it. But just that you know, there's not a lot of science behind this. It's hard to say, oh, it's too much, you should reduce it without having a number. That's one of the reasons I use this number. But it's a gradual increase in risk, right? The more calcium in the urine, the more of a risk of a calcium kidney stone. It's not a magic number, oh, I'm 249, now I'm out of the woods. Do you know that not only calcium is measured, but also the creatinine? Are you aware of that? Yeah. Do you know why? It's written there. It's it's a control. The simple reason is it controls for the correctness, the completeness of the collection. Why? Because in every single person, the excretion of creatinine from day to day is the same. So whatever you drink, eat, and whatever, right? And so in the ideal case, if you had 2 different collections of urine, right, one in June and one in December, the amount of creatinine should be plus minus roughly the same. But if one collection shows 500 milligrams and the other one 1,000, one of them is wrong, right? And either you're over-collected in one or you're under-collected in the other. And so if you remember that and have nothing else to do, you just look at your last 24-hour urine collections, look at the total amount of creatinine per day, and it should be roughly the same. And if there's an outlier, look then what the calcium is, right? If you under-collected and the calcium is low, you might be thinking, oh, my calcium is great in the urine, but it might not be. And interrupt me if you have questions, but otherwise we also have some minutes at the end. And so you're well familiar, though on the left side is how PTH works to increase the serum calcium, among others to reclaim the calcium from the urine. But on the right side is what happens if there's no parathyroid hormone. Nobody tells the kidney to kind of keep the calcium inside in the last part of the nephron, and you have a loss of calcium in the urine, and the more calcium and calcitriol you take in an attempt to increase the serum calcium, the more appears in the urine. Right? So that's the whole problem, and that leads us to this central challenge in the management of hypoparathyroidism, and that is on the right side, if the calcium is normal for the population, it's actually too high for people not on PTH, because that leads to hypercalciuria and all kinds of things. If you lower the blood calcium, you lower the urinary calcium. But you can only do this to a certain degree because otherwise you have symptoms on the left side, right? Hypocalcemia. And so the only reason why we recommend the lower part of normal or just below normal is the urinary calcium. There's no other reason. Otherwise, why would you do that, right? And so, therefore, if you're running on the low side as instructed, but don't measure the 24-hour urine calcium, something is missing, right? You should actually really be aware of the urinary calcium. And so what are the consequences of hypercalciuria? On the left side, you see the stones, and you've seen them yesterday. The most common one is calcium-containing stone, and among them, calcium oxalate crystals. On the right side, you see our very simplified, oversimplified thinking about this. So the higher the concentration of electrolytes like calcium, the more likely they will crystallize, right? That is in this picture. And the more you drink, the more you go down to the dilute ones, right? And so if you dilute, then you don't form stones. That's kind of easy to understand. Reality in medicine is always much more complicated. And so kidney stones, how many of you have or had kidney stones? Wow, that's quite a bit. And how many of those had painful episodes of kidney stones? Ouch. Okay. Here we go. So you are the best witness to talk about this. It's very painful, and the smaller, actually, the more painful, I was told, and the bigger ones sometimes don't move. But remember that kidney stones is not something that is specific to hypoparathyroidism, right? In the population, up to 10% of men will have had a kidney stone by the age of 70. That's pretty substantial, right? Doesn't mean an episode of pain, but having kidney stones. So urologists are, of course, the people who are involved. And so having a kidney stone doesn't necessarily mean it's because of the hypoparathyroidism, but it's a risk factor. So most of them are calcium-containing stones. These stones should ideally be analyzed because there are specific treatment options for the prevention of another stone depending on what kind of stone you have. And that's how they look like. You see on the left side, that's a CAT scan. That's kind of a slice through your body. You see the biggest organ there on the left is the liver. And then you see the lower parts, the two kidneys. And on the image on the left side, the right kidney has, sorry, it's called the left kidney here, but has a big white stone, right? This big white structure is a stone. And you see a similar picture on the right, a CAT scan that goes a slice this way. You see this huge white stone, and you can imagine this is not good, even if it might not cause pain, because it interferes with this nice function of the kidneys that we have alluded to. An ultrasound, they look like a weather forecast, but this yellow arrow here shows you where the stone is, and it has, with the white arrow, this particular shadow afterwards that's typical actually for kidney stones. And what is nice about ultrasound, it does not use radiation at all, right? So that's a very nice test. CAT scan is another test that's very specific and sensitive. So these were kidney stones. Now the other problem is nephrocalcinosis, and they are somewhat related. Nephrocalcinosis is really the presence of calcium salts within the tissue of the kidney. So not just in a tubule hanging somewhere, but within the tissues. And if you see the CAT scan on the left lower side, you see these little white dots right and left where the kidneys are. These are calcifications, so calcifications of the actual kidney tissue. And on the right upper one, the one with the right and the two black spots, these black spots are calcium crystals. This is what nephrocalcinosis is, and it doesn't go with pain, but you can see it on imaging, and this can reduce the kidney function. All right, and so speaking of kidney function, that's the third one. The hypercalciuria can lead to impairment of kidney function. CKD, we say, chronic kidney disease. And so there are blood tests that you know, creatinine and BUN, that tells you something about it. And then there is a calculated result that's called GFR, or estimated eGFR. That's the glomerular filtration rate. The better the GFR, the better the kidney function. And so we have different stages. And people, yesterday somebody said, I have stage 3. So what is stage 3? That is if the filtration is between 30 and 59 milliliters per minute. the differences between like 90 and 80 is extremely small. It's within kind of the almost normal range, right? But then when you get down to less than 60, then differences do matter actually, or can matter a lot. And therefore there's also a 3A and 3B, with 45 being the threshold between the two. And then very severe and end-stage renal disease, that means dialysis, actually, right? So the higher the GFR, the better, actually, in general. And so remember, though, that there are risk factors for CKD that are more widespread than hypoparathyroidism. And so diabetes and high blood pressure are the most common ones, and you want to be very concerned about these and having good control for your kidney function. How many of you have high blood pressure or are treated for high blood pressure? See? So that's kind of where you really have to watch out. You want to be very cognizant about your blood pressure. You measure it at home. You have a little list or an electronic ways. You go to your doctor, you show that, not just one measurement in the office. And you put a lot of energy into the control of the high blood pressure. This is what is really important for your kidney function. Hypercalciuria, high calcium in the urine, is also, but really these are very important. Remember that the GFR as we get older, and my definition of old changes every year, as we get older, the GFR naturally declines, right? And so if you have a GFR of 68 and you're not the youngest, it might be just because of age. Nephrocalcinosis, as we said, is probably a risk factor. It's actually hard to study this whole connection in hypoparathyroidism because there aren't a lot of big studies that really show us. So we deduce a lot from our knowledge from non-hypopara patients. And then one question is, does it progress, or how fast, how slow, right? So let's say it is slightly impaired but stays pretty stable over many years. Well, that's obviously a good thing. And so we did, many years ago, a study in 120 patients in the Boston area with chronic hypoparathyroidism, and we asked several simple questions. One was, how many had a 24-hour urine that we could find in the electronic medical record? And guess what? Only half of them had one. Right? It's a problem. Of those who had one, you see on the right side in this dot graph the 24-hour urine calcium, and the gray is more than 300. There were quite a few who had more than 300 milligrams per day, and that's high. Now, what about imaging? And so some had imaging for whatever reason, and when we looked at them with the radiologist, we found that about a third of those who had imaging had actually kidney stones or nephrocalcinosis. And you see a more extreme example here on the left side with kidney stones on both sides. Now, what about the kidney function? Here we remember the lower the GFR, the worse, and so here we define it as less than 60. And on the right side, you see in black a very important graph, and these are US databases from people of all walks of life. You see that the CKD prevalence is higher the older we get. Right? If you follow the black bar, you have 20 to 39-year-old, 40 to 59, etc., and older than 69. The percentage of people with CKD increases. Now look at the gray bars. These are our patients according to age with hypoparathyroidism. So you clearly see it's higher than in the normal population. So we really have a problem, right? It's not just theoretical. And this is from a review that actually took studies that were published about the prevalence of CKD in hypopara patients. You see, several studies listed here with the date, the year that were published, and particularly of interest the number of patients. You see there's some smaller studies, 33, and some very large studies, 688. And you see the percent of patients with CKD. It doesn't tell you really what the age was, right? And so the older the population, the more likely. But it gives you a range, and it just happens that our study had actually the highest percent of patients with CKD. Now, let's look in more detail about to the last study with 688 patients. This was a nationwide Danish study where in Denmark everybody is captured electronically. And they took post-surgical patients, 688, and chose age and sex matched controls, and found the risk of kidney disease in patients with post-surgical hypoparathyroidism was about 4-fold higher. That's a pretty stark number. But you also need to know 4-fold of what, right? If there is a very low risk and you have a 4-fold risk, it might still be low. And so that's not often talked about, but I put the number from this article here for you. So you see the risk of kidney stones in the controls, 2,000 controls, was 0.4%. In hypoparathyroidism, it was 1.9%. And you decide for yourself, is 1.9% very high or very low? It's obviously higher than non-hypopara patients, right? But it's not like everybody gets kidney stones. And CKD, chronic kidney disease, the function of the kidney, similarly 1% in controls and 5-fold higher, 5.1% in hypopara patients. So you get a little bit of an insight into the numbers, right? It's relative risk, meaning how many fold higher is one part, but then what's the absolute risk, like in percent, which you see here. So I just threw this in. Just let's talk about a practical case. So we have somebody who is otherwise healthy but has post-surgical hypoparathyroidism and comes to the office with the following medications: citrical, 6 tablets twice a day, calcitriol, 1 capsule, levothyroxine daily. And here you see the serum calcium measured, over several months, ranges from 8.5 to 9.9. Serum phosphate is slightly elevated, and the 24-hour urine is there. Normal vitamin D, magnesium, TSH, occasional tingling. What do you like and what you don't like, and what would you do here? Oh, I like that. So lowering the calcium tablets and increase the calcitriol. It's an excellent point. Why? Well, it has many different reasons. One is 12 tablets of calcium. That's quite a bit, right? Who takes more than 12 tablets of calcium per day here? Ooh, I'm glad to see that. Nobody. Excellent. It's impossible, to be quite honest. Why not increasing calcitriol, right? That you get much more bang for the buck. It's very potent. It's in micrograms. There are 0.25 and 0.5 microgram strength. So if you're on a higher dose, you can switch to the 0.5 if you and your doctor agree. Excellent. Then twice a day calcium, right? Is that enough? No. Instead of having these 2 peaks of serum calcium a day, because calcium is relatively short-acting, you want to have 3 times a day or sometimes 4 times a day. If you take it with meals, which we recommend, you also bind the phosphate. It's one of the ways of lowering phosphate, right? So there are lots of little things. So what did we do? A little hard to read here probably, but we switched this patient actually from calcium citrate to calcium carbonate. We can talk about this in more detail. You don't have to do this, but for this patient it was fine. What you get is you get more calcium per tablet. So if you don't need citrate and you don't have other reasons, then calcium carbonate actually is a fine choice. 3 times a day with meals. So we lower the total amount of calcium from 3.7 grams a day to 1.5 grams, which looks much more reasonable. And we increase the calcitriol and give only 1.5, and indeed the serum calcium overall went probably down a little bit, but didn't have these swings. Serum phosphate more or less the same, maybe a little less, but the 24-hour urine really went down, right, from the 350 to 450 to 290, and rarely symptoms. So that's actually a good thing. And There are many other ways. Now, what do you do with the 24-hour urine if you want to be lower than that, right? It's getting a little difficult, but what can you do? One is exactly what was said, that the decreased filtered load of calcium can decrease the urinary calcium. So you want to lower the serum calcium if possible. Now, if you're running at 8.0 already, well, you don't have much room, right? But if you're 8.7, maybe you can go to 8.3, right, on average. And so only you and your doctor can decide what number is too low and what not, and that differs between people, right? And when I say numbers, it's just a number that I often see. It doesn't mean it applies to every one of you. The distribution of calcium supplements evenly throughout the day is really important. Advocacy, you've heard about this. This is a medication that can lower the urinary calcium if you have a low salt diet. Otherwise, it doesn't work. And of course, PTH or PTH analogs, right? That's the obvious drug that is missing and can actually lower the urinary calcium. Reducing pill burdens. So I really, in the past, we treated too many people with too much calcium, actually, and so now calcitriol is really a help here. Calcium carbonate is okay for many patients. And so kidney health, what can you do? So one is keeping the serum calcium as low as you can, and divide the calcium throughout the day. And then also one question that came up yesterday, I think, was the timing of the calcium check, right? So in the morning, before you take your morning medication, it's the lowest calcium of the day for most people. Are you interested in that? Sure, if you want to avoid symptoms, but you also feel the symptoms in the morning, right? But what about in the middle of the day? Well, some of you might see your doctor in the middle of the day and have labs done then, right? And so they might be slightly different. So I personally, if you can, encourage you to have both. Several calcium values that are presumably the lowest in the morning, and then several throughout the day. See how the calcium is. And if you see, well, actually, it is pretty high during the day, I don't have symptoms in the morning, you might be able to lower it. Or you might be able to switch the last calcium of the day later at night. All these little things matter because it's not a disease that you take tablets for a week or 10 days, like an antibiotic, and then you're done. Here, you really want to fine-tune. And so the 24-hour urine calcium measurement, we talked about calcium and creatinine, but there's also another measure that you can take, and that is was mentioned yesterday, litholink. So stones form because of an imbalance of inhibitors and promoters of crystallization. Calcium is just one of them, so the picture is more complicated. There are also inhibitors that you want to have of the crystallization. And they can be measured by a so-called stone profile of the urine. And so this is what it can look like. And you might not see all the numbers, but it kind of lists on the left side several electrolytes like calcium, oxalate, citrate, etc. And then it gives you the numbers and it kind of displays them. Green is good, yellow is okay, red is too much, right? And so it's visually very easy to actually see. And then you can see, oh, my volume is 1.5 liters. This test tells me I should actually have a higher volume, meaning I should drink more, right? Or oxalate is too high. Oxalate is bad for kidney stones, and it's in everything that's good, like chocolate and nuts, etc. So you might have to think about what you eat. And then it gives you also a table, and it lists everything, it lists the normal range and stuff. So for those of you who had kidney stones and who haven't done that, talk to your doctor about this, right? It can be actually very useful. Also talk to a nutritionist if necessary. Fluid intake, very important. Diet, sodium and proteins, so meat, can actually increase the risk of kidney stones. Thiazides, we talked about, lowering oxalate, and if the citrate is low, your physician will talk to you what to do, but one thing is potassium alkali. And don't forget, for kidney health, blood pressure, diabetes, and weight. All right, so that was what I wanted to talk about. Thank you very much for your attention, and I'm happy to take any questions.
Thank you.
Hi. So those of us that have stones, if we get any that are bigger than 5, luckily I haven't yet, what is your position on lithotripsy? My care team is split. One has said don't ever let them use that on you because it's more damaging to the kidneys, and the other has said it's fine. What's your thought?
Yeah, excellent question. I have to tell you that I'm not the right person to answer that.
Okay.
What I would say is depends on the size and location. And the best person to talk to is the urologist. Now, it's like going to the hairdresser and you get a haircut, right? And so you go to the urologist, they might actually favor a lithotripsy, but they are the ones who have the best experience and will tell you.
Hi. Okay, my urine calcium was 720,
Wow.
but I'm only taking 900 milligram of calcium. What are your thoughts on that?
And do you take calcitriol?
Yes, 2.25. No, 0.25 2 times a day.
Got it, so 0.5 a day, right?
Yes.
Yeah, and what is your blood calcium?
It was 9.3.
Yeah, so the calcium excretion has a huge variability already in people without parathyroid disorders, right? They can usually be in the 100, 200 range, but there are people running around with way higher levels, and they have nothing wrong with their parathyroids as far as we can tell, right? And so Dr. Roberts had talked about this, the idiopathic calciuria. So you might have had that before you acquired hypoparathyroidism. But I would argue, first of all, you are not different than the mean level of calcium and calcitriol that you need for hypoparathyroidism, even if people attending this conference might actually on average have a higher requirement, right? But if you look at large studies, 0.5 and about a gram is kind of the mean. But it might be too much for you. So a serum calcium of 9.3, which is smack in the middle of the normal population range, is exactly what I was talking about, this balance between a normal calcium, which is too high for hypoparathyroidism, and the hypercalciuria. So you might want to, if you haven't done already, try or consider decreasing calcitriol. And see what does your blood calcium do and what are your symptoms, and if both are okay, then check your 24-hour urine and see how this develops.
So it's better to lower the calcitriol right now, not the calcium.
Yes, so that's a detailed question, depends on many factors that we might not be able to discuss now. In general, if the calcium intake is roughly what a person with normal parathyroid should take, like 1,000 milligrams a day, if that's your intake, I would not really change that too much, but then switch the calcitriol. There's an exception, and that is if your serum phosphate is high. It is high? Well, exactly. So then
It's 4.9.
keep the calcium, right? Because that binds the phosphate and lower the calcitriol. So it's relatively straightforward in your case. Here we want to decrease, so we decrease the calcitriol and keep the calcium tablets. Sorry if that was confusing.
So I became hypopara in 2007. I finally convinced my endo to do a 24-hour calcium in 2019. That
Good for
was
you.
my first one.
Good.
At that point in time, my creatinine was 1186 and urine calcium was 289. The next one that I finally convinced them to do, actually because of having some issues, was in November 2020. And my urine creatinine was 2390 and my calcium was 605. And they didn't say there was anything I needed to do. We did trial HCTZ. Unfortunately, I had some other complications, so I couldn't take it. I'm on aldactone, which supposedly, I guess, does something similar, and I'm doing okay with that. Should I be trying to get them to do another one now?
Yeah, no, it's nice that you have the numbers. You realize that your two different collections had 200% of the first one was your creatinine, right? So that doesn't add up. And it's exactly what I was mentioning. You had 289 and then you had 600, right? So let's say your first one was the correct one and you over-collected for the second one. Then if you cut it by half to get about 1.1 gram of creatinine, your urinary calcium now is 300 and something, right? It's still a little high, but it's very different from the 600. And that's precisely why I mentioned the creatinine. So it's good that you have the numbers. Now, how do you decide which one is the correct one? It's a little tricky, but women, so it's a muscle mass question, right? And so if you have a young bodybuilder, 2 grams is kind of what they have. If you're a woman and not a bodybuilder, you might have 1 gram or even less. If you're a very tiny, fragile 70-year-old woman, you might have 0.5 gram, right? And so it looks to me that there's a possibility that the second one was an over-collection. How do you over-collect urine, right? I mean, you want to get done with that. One reason is that the first morning where you should discard the urine and then start, you might not have discarded it, right? You might have collected that and the next morning one. Or if your volume was very high and you needed 2 bottles, what does the lab has to do? They have to mix them and then take a sample and measure it. Because one might be when you really drank a lot and it's very dilute, or at night you didn't drink at all, it's very concentrated. And if they only measure one, well, it's useless, right? And guess what? It happens again and again. It happened this week, actually, to one of my dear patients who already got crazy because I wanted so many urine calcium. And he collected, he had a huge volume, which I always like. And I told him, well, tell the lab to mix them. He did, and they said, who's the doctor, you or me? And they didn't. And then the mother he's a young guy, mother actually was very inventive. She they collected the urine, 2 bottles, put them in and put a tape around it as a, per my doctor, please mix before you measure. And they did. And it was half the value that was there before, right? So these are the little things that matter.
Okay, we have some online questions.
Okay, I'm going to start with, can the body dissolve or reabsorb kidney stones once your calcium levels are properly maintained?
Excellent question. Now, previously I would have said no way. But in children, nephrocalcinosis or calcifications can come and go. In adults, I'm less sure. So I would presume they more or less stay.
Okay. Is chronic kidney disease reversible, and if so, up to what stage?
Excellent question. So that depends on many factors, among others, why the kidney function was impaired. Typically, it's not really reversible unless it's something acute, and the acute setting, it can be reversible. Children, everything is possible. And there is also a day-to-day fluctuation of GFR, and it depends, among others, on your hydration status, right? So you might have stage 3 with 55, and then the next day you have 61, and you say, whoa, look, I overcame this, right? And these are relatively small changes. So it depends on many factors.
Okay. Is it important for us to include a urologist on our treatment team? When should we see them? And is there a criteria, or should we see a nephrologist instead?
Excellent question. That all depends a little bit on you and your primary care physician and what the degree of your disease is. So in general, for kidney function reduction, so for instance, CKD stage 3, etc., you want to see a nephrologist. And so you should talk to your PCP and saying, well, I see that my GFR is X, Y, and Z. What do you think about seeing a nephrologist? And what does the nephrologist do? They don't do magic, but they will be very good in identifying risk factors and what you can do about it, right? Blood pressure being one of them. If you have a kidney stone, then you might want to have a urologist on board. So the question, which one can be destroyed or should be or not, right? That's a urologist who can tell you.
Then they fight sometimes.
And you see, yes, yes.
That never happens, right, Dr. Manstead? All right, so thank you so much for your time, and I know you got somebody else you want to introduce to us.
Yes, great. Well, thank you very much. That was fantastic. So I have the pleasure of introducing the next speaker, Shui Wang. Dr. Wang comes from Virginia Commonwealth University, drove this morning here. He is, yes, Virginia, here we go. Fantastic. So Dr. Wang is an assistant professor and in the Department of Chemistry. He's a PhD. He doesn't treat patients with hypoparathyroidism, but he is doing something very special. He's interested in measuring minerals, among others calcium. And so he has dedicated a lot of work into trying to find a way to devise a self-measurement device for calcium. That's what we've been waiting for all year long, right? So there are many things I can say, but Dr. Wang talked to me one day about this, and I said, yes, there's a big need, right? And then he asked, well, what is needed, what volume, what precision, et cetera, and how big, and blah, 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 and we talked. And then, a year later at the meeting, he said, can we meet? And so we met. And he said, okay, you had these 5 different requirements. I did number 1, I did number 2, I did number 3, and I did number 4. What do we do now, right? So I'm very impressed by his work, which requires resources. So if anybody has an idea of having a fundraising for this enterprise, it would please talk to Dr. Wang. And I am happy that he came here today to talk about his development of a calcium measurement device. Dr. Wang.
So thank you very much for your invitation and the introduction, Dr. Manstead. So my name is Shui Wang, and I have a research group at Virginia Commonwealth University. I have a few research directions, including implantable sensors, bedside continuous blood sensors, and home use sensors. So I cannot use laser. Okay. So the home use sensors, we focus on electrolytes, including calcium. So I had my PhD training in the area of ion sensors, where calcium is ion, so including calcium sensors. And then I did my postdoc in 2 research areas, ion sensors and glucose sensors. I was actually a GDRF advanced postdoctoral fellow working on glucose sensors and insulin infusion sets. So I do know glucose sensors and calcium sensors. So sometimes I got this question from patients. So why glucose meters are so well available on the market and calcium meters, you can't find them? So what is the reason? Well, I try to share my personal understanding about the reason. Well, there's no standard answer, so I cannot guarantee what I said is definitely 100% accurate, but I do my best. So I want to show you the history of these 2 sensors to have a comparison. Well, glucose sensor is actually enzyme-based glucose sensor. It was invented in 1962 by a professor called Dr. Clark. So Dr. Clark invented an oxygen electrode first. So the electrode has a name of Clark electrode, actually, Clark oxygen electrode. And then he covered the oxygen electrode with glucose oxidase. Glucose can be oxidized by glucose oxidase in the presence of oxygen, and the oxygen will be consumed, and he uses his oxygen electrode to detect the loss of oxygen to indirectly indicate the concentration of glucose. Well, that is the first version of glucose enzyme electrode, 1962. And then after 13 years, 1975, the first commercial glucose electrode became available. It's from a company called YSI, that is Yellow Springs Instrument in Ohio. So after 6 more years, the first home use glucose sensor was launched by Bayer. So at that time, well, the analyzer, the glucose meter needs like more than 10 microliter blood. It has a brand name called glucometer. So it is actually a brand name, but because it's the first version, now we still call a lot of glucose meters glucometer, even though it's not actually glucometer brand. So while that is the first version, we know over time, home use glucose meters improved a lot. For example, it no longer requires like 10 microliter blood. It's a much smaller volume. And 1999, so the first continuous glucose monitor became available. So it is from a company, MiniMed. Later, this company was acquired by Medtronic. And 2006, the first artificial pancreas became available. So, well, this term means the closed loop system comprising a continuous glucose monitor and an insulin infusion set. So based on the reading of the glucose monitor, the dosage of insulin infusion is controlled to reach a desirable glucose level. So it's quite advanced level. Well, now if we look at calcium meter, it was invented in 1967 by Dr. James Rose at a company called Orion. So this company is actually in Cambridge, Massachusetts. So actually that is a professor, Dr. Eisman at Harvard Medical School, who was a consultant of this company. So that professor helped with the invention of calcium, the first calcium electrode. Well, 1985, in blood gas analyzers, so for the first time, calcium electrode was added into the blood gas analyzer. So if you go to a hospital, you have a blood draw, they can tell you the ionized calcium concentration by using this kind of calcium electrode. And then, 1991, the blood gas analyzer became smaller. So Abbott had the first handheld blood gas analyzer, so including calcium detection function. That's 1991. I think many of you know the iStat product. What's next is blank. So after that, I'm not aware of a lot of progress in the area of calcium meters. So it's 30 years ago, 1991. So this is a huge disparity compared to glucose meter. Okay, so if we compare the status today, for glucose meter, for patient use, 2 versions, disposable or continuous. Disposable sensor for finger prick blood. The required volume is only 0.3 microliter, 0.5 microliter. So one small drop is 5-10 microliter. So you get any tiny drop of blood, that's enough. Very easy. The cost, well, $20, $50, $100 analyzer, and the strip is, well, very cheap. For continuous monitor, for glucose, nowadays, you know, the Abbott product, including the Dexcom product, they can last 14 days already with no calibration. How about calcium sensors? Well, nothing have been approved for patient use at home. Well, the only possibility is, well, it's not approved for patient use, but you don't have any other options, so you use iStat sometimes. But iStat needs 95 microliter blood. think about the difference. 0.3 microliter, 95 microliter, that is a huge difference. So it's a lot of effort to collect 95 microliter blood from your fingertip. And the price is way higher. So again, the disparity is huge. Well, why? What's the reason? So I talk about the non-scientific reasons and the scientific reasons. Non-scientific reasons, easy to understand. So the market for diabetic patients, management of diabetes, is much, much larger than the hypopara patients. So also for glucose monitoring, it needs very frequent monitoring. Calcium, at least not as frequent. Then you don't need so many strips, so many cartridges, and then the market is small. So I just show you one example. So there's a company, a startup company called BioLink. 2 years ago, it just raised 100 million to develop a new version of glucose sensor. We think it's already very good, but they try to make the needle even shorter, to have a micro needle array to make the sensor even less invasive, to further improve the life of diabetic patients. This is just one example. If you think about Dexcom, Abbott, Medtronic, how much money they put on glucose meters every year, it's a huge amount of money. How about calcium meters? It's about zero. If it's not zero, it's about zero. So I have an example. So glucose sensor is already at a very advanced level, but still they want to feed glucose sensor the best resources as much as possible. Calcium sensor is far behind, and nobody cares. So that is a very big problem, because sometimes we talk about like equity, inclusion. That is not equity, that's not inclusion. We ignore the calcium meters, we ignore the hypopara patients in terms of the technology, the diagnostic technology. So, well, that is the first reason. The second reason is research groups in universities, academia. So if you compare groups working on glucose sensors, hundreds of groups worked on glucose meters. Calcium meters, you can only find a few. There are many groups working on like calcium bioimaging, but that's a different concept. That is not the meter for in vitro diagnostics. So it's another very big reason. And then scientific reasons. So actually, calcium meter is harder than glucose meter, very unfortunately. So why? Number one, so I showed two typical response curves of glucose sensor and the calcium sensor. So the left one is glucose sensor. The electric current, which is the signal, is proportional to the concentration of glucose. It's like if you have 3 millimolar glucose, you may have 300 nanoamp current. And if you have 20 millimolar glucose, you may have like 2,000 nanoamp current. So this linear relationship. And the glucose concentration ranges from 3 to 20 millimolar. I labeled this range using the pink area. If you look at the calcium sensor, the electric signal is proportional to logarithm of ionized calcium concentration. There is a logarithm there, which is very bad. Because of that, the calcium concentration range, also labeled as the pink area, is super narrow. Actually, most signal for the calcium sensor is wasted, has nothing to do with the clinical range. So if you look at here, it's wasted. But for glucose sensor, it's not wasted at all. So for glucose sensor, so the actual response is very large. For calcium sensor, for that clinically relevant range is so tiny. That is very hard. That makes calcium detection harder. And number two, well, it's even harder to understand. Number two is glucose sensor has a baseline. What does baseline mean? If you have no glucose, so you have no current, it's zero. But calcium sensor has no baseline. If you have 0 calcium, I randomly put a 0 there, but that's a random number. So for electric potential, there's no concept of zero. Zero is always relative to a reference electrode. If you use a different reference electrode, this number can become 200, can become negative 200. So the reading for calcium is more random and it's kind of flying in the air. It's much harder to control. So because of that, when you make 1,000 sensors or 1 million sensors, they vary a lot. They vary a lot. And then for the same calcium concentration, you will get many different results because the sensor is different. That's not what you want. So the sensor to sensor variation is very large for calcium sensor, but glucose sensor is better. And the worst one, the requirement for calcium measurement is even much higher than glucose measurement. Glucose measurement, if you have 20% error, not a problem. And some initial products have 30% error. It's like 20% error means if your actual glucose concentration is 5 millimolar, the result from the sensor may be 6 millimolar, maybe 4 millimolar. So this kind of error. It's not so bad. But calcium, so typically we want to have an accuracy of like 0.1 milligram per deciliter. It's much smaller than 5%. The sensor itself is so hard and the requirement is much higher. That's the problem. So it's not very easy. So sometimes we think, well, glucose sensor is so well established, its success should somehow help with the development of calcium sensor. But unfortunately, they are not similar at all. So they are completely different. The design, the signal, the recognition mechanism, everything completely different. So glucose sensor does not help with calcium sensor at all. That's very unfortunate. So, okay, our group works on 2 directions. So we try to solve the problem of sensor-to-sensor variation and the too small response because the range is too narrow. So we try to work on these 2 things. Well, I want to clarify one thing, that is I'm a chemist and I'm working on something quite fundamental. So I do not have a beautiful product to show you. But I think I'm laying the foundation. That is more important. Actually, it's very easy to show you a product, but it may not be accurate. It looks very beautiful, you are very excited, but the inside, yeah, could be very problematic. So I won't go into details, but the first thing we did is we developed unselective electrodes with the baseline. I mentioned unselective electrodes, well, which is the calcium meter. The technology is called unselective electrodes, have no baseline, but we somehow are able to create a baseline. Because of that, we dramatically reduced the sensor-to-sensor variation. So if it's a regular sensor, they easily have like 50, 60 millivolt variation. It means an error of about 1,000%. That's huge. So that's not better than guessing. But with our new design with the baseline, so the error becomes 1 point something millivolt, which is an error of a few percent, so which is much, much better. So we call this self-calibrated unselective electrodes. Well, but we actually focused on potassium in our first publication. The reason is very simple. Potassium detection is slightly easier than calcium detection. So we focused on potassium and we tested multiple blood samples. We proved our method has a lot of promise compared to other methods. We have much better accuracy. So I want to summarize the status of this technology. I don't want to go into technical details because this is not a chemistry conference. Well, so we filed international patent for the technology, and we also published the first paper using potassium as example. So very fortunately, now we have a fund for this direction. We have an NIH grant, and we also have a grant from Virginia Commercialization Fund. So now we are able to include calcium because that is in the specific aims. So in the beginning, we don't have money. Well, we can choose the easy one, potassium easy, we do potassium. But now we have to include ionized calcium. So, well, but this is a very big change compared to traditional sensors, and there are a lot of fundamental things to understand, and it will take a while. It will take a few years at least. It won't be available like in 1 or 2 years. And another thing about this method is potentially it could become a continuous calcium monitor, because this is electrochemistry. We can make a small electrode and implant it under the skin, just like the continuous glucose monitor. So it has this potential. So this method one. So the second technology is inkjet printed paper-based sensor. The reason for doing this is we want to reduce the sensor-to-sensor variation to fabricate identical sensors. And we know inkjet printing can print things very consistently, precisely. So we actually pioneered the inkjet printed on sensors. So we have the dye on paper, and then if we have different concentrations of calcium there, it's different color. Well, we published a lot of papers, and it's very good. And then we try to detect the blood. Here's the thing. You can't add a drop of blood onto this sensor, because otherwise you will only see one color that is red all the time. So you have to have a plasma separation membrane. So you have the sensor and then plasma separation membrane, and then you add blood. Only plasma diffuses across the separation membrane to reach the sensor to change the color, but the red blood cells are trapped. That's the only possible design. We worked very hard on that. What we found is the plasma diffusion is not so uniform. We tried many different stacking methods. We tried vertical flow, we tried lateral flow. It's always not uniform enough. If it's not uniform enough, the error is large. The sensor is identical, but the entire device is not identical enough, and then it's not good enough. Well, but Dr. Manstad mentioned the urine detection. Then, if we think about this technology, it may be very easy to do urine detection, because urine at most is yellowish, so we can correct that color, but it's not like dark red. And this is very cheap, very easy to fabricate. We can print some kind of dipstick for you, the strip, and you can dip it into the collected urine. So, and then you have a smartphone to take a photo, and we have an app to tell you the calcium concentration. That is certainly possible, but we didn't pursue that because we have been focusing on calcium in blood. Well, this one didn't work, but we can't simply give up. So we think, how can we avoid using plasma separation membrane, which is the problem? We found this new design, that is, we have a segment of liquid sensor. Liquid sensor is like, think about some kind of oil, for example, soybean oil. I add some sensing dyes into the soybean oil. And then I have this kind of design. The oil is in a capillary tube or a pipette tip, and then we aspirate a small drop of blood into the tube, and then we do mixing. At the end, we check the color of the oil using a smartphone. Then you don't care about the color of the sample. It's red, it's transparent, it's whatever, because you only pay attention to the color of the oil. The oil is next to, it's adjacent to the sample. They do not overlap. They do not cover each other. So by doing this, we can detect whole blood without any separation of blood. So that is a big deal. And also, we found that we have very good reproducibility, meaning sensor-to-sensor variation is very small, because liquid sensor is very easy to prepare. Well, the detector is also a smartphone. So it looks pretty complicated, but for a patient, what you need to do is you insert a disposable capillary tube with the sensor preloaded into a stepper motor, and then you add a drop of blood at the end of the tube, and that's all you need to do. The rest is done by the machine. So it's very similar to the glucose meter as well. You insert something and add a drop of blood. Even though the device will be larger than the glucose meter, it may be this size, but I don't think that is a huge problem. So as long as it is convenient for patients. So actually we had I call it breakthrough for the colorimetric response, because I showed you the response is always wasted a lot because the detection range is too wide. So that is also true for colorimetric sensors, not only for the electrodes, both. And this is what I showed. So the response range is so wide and the actual range is so narrow. We are able to develop new chemistry that shows an extremely steep response. We call this gate-like response. So only for the clinically relevant range. So we do not waste any signal. Our color change from blue to yellow, it only happens for the clinically relevant range. So this is a very big deal in my opinion. So for example, here we have 1 millimolar calcium to 2 millimolar calcium. The color changes from blue to yellow. It's a very big color change. You can tell it easily from your eye. So, and we tested whole blood. So you can tell here, we have triplicate for each blood sample. And I have 5 blood samples with an increasing concentration of calcium. You can clearly tell first, the reproducibility is very good. For each triplicate, there's no difference in the color change. So it's the same color change. And also, the result for whole blood matches the result in standard solutions very well. So we tested 51 blood samples, and the overall error is very good. So for most samples, the error is below 5%. That is very encouraging for a brand new concept and a brand new chemistry. So, but there is a problem. We do need hematocrit correction. That is not something very new. Actually, glucose sensors, glucose meters also suffer from interference from different hematocrit. So some glucose meters even have the integrated hematocrit sensor. So then I think, well, can we integrate hematocrit detection into the same device and patients can't even notice it at all? So that's my goal. And we did some work and we got very promising and very exciting results. So we are able to differentiate blood samples with different hematocrit with very good accuracy. So, and we did not add a separate piece to the analyzer. It's still the same thing. We just use some different protocols of mixing or different oils, but it's the same device. So you won't feel this at all, but we can provide the hematocrit correction. And so Dr. Manstead told me, so albumin is also something important because we are testing total calcium here, not ionized calcium for this colorimetric method. Then if we can include albumin, it will be very helpful. And we tried that. So we did not finish this. I cannot see. I will definitely be able to make it work, but we did get promising results so far. So for this one, well, first, I work on this direction because of the fund from Orphan Disease Center 2-3 years ago. Otherwise, I don't know this need, and I won't work on this at all. So, and then I want to thank Kelsey Lytics. So they provided fund so I can develop the extremely steep colorimetric sensor for calcium. Otherwise, it won't happen. And we published the paper, and we also filed the international patent. And currently, we are trying to get new fund so we can integrate the hematocrit, and we can do some more blood samples. Actually, we got our IRB protocol approved in August at VCU, so to test samples from real hypopara patients, so we can have a much wider range of calcium concentration. So that is ready. And we are also working on many other aspects like engineering, like commercialization, and hope to push this direction to a reality, because I think this will take much shorter time than the electrochemical method. And my goal and my dream is to commercialize this in a few years if we have enough resources. Okay, so I want to end my presentation with something more positive. So calcium detection is not alone. The challenge is not alone. Actually, there are a few companies which are developing at-home monitors for other blood electrolytes like sodium and potassium. They typically share the same platform. Yes, definitely they need some adjustment optimization, but if somebody can't develop a potassium sensor, sodium sensor, it may be used for calcium as well. So that is some more hope. Okay, so my postdoc and my students did the work, and we want to thank the funding agencies again. That's all I have. I'm happy to answer any questions.
Thank you very much. Thank you so much. Do we have any questions in the room before we go online? Okay, Michelle?
I want to say thank you. And when you get to the commercialization process, the Department of Pathology and Laboratory Medicine in Indiana University would be happy to be a host site. I've got a large industry-sponsored trials group. I employ med techs, and we will give you the friends and family discount. So keep me in mind, okay?
I appreciate that.
Hoosiers will help you.
All right, anybody else? Questions? All right. Well, thank you so much, Dr. Oh, we got one? Oh, here we go. Sorry.
Three or four people just popped up online also to say thank you very much and thank you for taking notice of our population and for continuing your work even though there's such a small portion of us. We really, really appreciate you putting in this effort and explaining to us why it is not so easy to make a calcium monitor, because I know a lot of people think that you can just take the glucose monitor and modify it, and you've done a very great job today of explaining why that is not possible. Thank you.
I'm dedicated to this. I will try my best to make this work.
I had a question whether your device is intended to be an at-home or whether it's intended to be portable.
Both, so portable,
Okay,
so that
it
can
can
be used at
handle
home.
being stuck in a pocket and walked around with.
Well, it's not that level of portable. I
yet.
cannot guarantee, but it can be. You can move it.
Okay.
Yeah, you can carry it, but not in the pocket probably.
Okay, that's fair.
Okay,
Just curious.
There are some questions popping up online now. Did you do any ISTAT comparisons?
Well, we are testing total calcium. We do not use ISTAT, but we did have a commercial total calcium test kit as the reference method.
Okay, and there's a couple people wanting to know, is there a way they can watch your progress? Do you have a website or anything that they can look at?
I have a website, but I unfortunately do not have details on this specific direction, so I will add it.
Thank you.
All right. Well, thank you again, Dr. Wayne, for your time this morning. And for everybody, we are having lunch again in the lobby out there, and we'll be back in the room at 12:50. So enjoy, and thank you so much again, Dr. Wayne.
All right, welcome back, everybody. Welcome back to you all online. We're so happy that you are with us today and watching all the great things that we have happening. So we are fortunate to have Dr. Dolores Schoback back to us today, and she's going to talk to us virtually live. And reminder that she is from UCSF Health in San Francisco. So welcome back, Dr. Schoback.
Good afternoon, everyone. It's a real pleasure to be able to talk to you today. I really, really wish I were there in the room because that's always such a great energy. But I'm thrilled to be able to talk, so I'd like to go ahead and start my presentation now. So I get to talk to you about, I think, what's a pretty challenging topic, even for us who have been working with people with hypoparathyroidism for a long time, and that's calcium versus thyroid. When they're low, what's causing my symptoms? So I have nothing to disclose with respect to this topic and no conflicts of interest. So just a couple of quick facts about the parathyroid glands, and then we'll talk about the thyroid a little bit also. You know, because you have dealt with this disease for such a long time, that these are very tiny but very powerful little glands. Our bodies have 4 of them, and they're tucked right behind the thyroid, which makes them very intimately involved with each other all the way through. And this is just some facts about them. They're very tiny. You can see about 1,000th, 2,000th of an ounce in size for each one. And they only do one very, very critical thing in our bodies, and that's to make parathyroid hormone 1-84. And pretty much every single tissue, as you'll see shortly, in our bodies needs the effects of parathyroid hormone, mainly on the blood calcium, but some of the effects are through parathyroid hormone itself. And the main job of parathyroid hormone, as you all know, is to control the blood calcium through its effects on the bone and the kidney. But there are so many other tissues that care about PTH as well as the calcium level. So when there's not enough PTH in our bodies, hypoparathyroidism occurs. And what you're looking at is what we kind of often call the biochemical profile of the condition. Okay, the PTH levels are low, the calcium levels are low, the phosphorus levels tend to be high, bone turnover gets shut way down to a low level. And often because of our treatment for a hypopara, the urinary calcium levels go high often. So this is the biochemical profile that you all know so well, and that we often are looking very closely at when we see you in the office. We're looking at all those, hard pieces of evidence as to how things are going. But what we know from so much work that's gone on over many, many years is really what's shown here, that like all of the systems practically in the body are affected in hypoparathyroidism. And you can see in the top little green boxes where I've put the red stars, the central nervous system, that's our brain, of course, and the neuropsychiatric system, which is our brain and our minds, if you will. And then down in the lower left, the peripheral nervous system. These are all really important systems when it comes to the effects of a low blood calcium or a very low PTH level. And in the central nervous system, seizures can occur over the long haul. Calcifications can occur in the brain. There can be, on the neuropsychiatric side, there can be symptoms of anxiety or depression or other neuropsychiatric manifestations. We look down in the lower left corner, very important, and sometimes things that you feel every single day. The peripheral nervous system can be involved with what we call paresthesias. That means funny feelings, things that aren't normal, tingling, numbness. These are not normal things. And then muscle cramping and tetany. And then if we look at the other body systems that are listed on this slide, you can see that the heart can sometimes be involved, the lungs and the trachea can be involved, the kidneys, of course, and there's a lot on the kidneys at this particular meeting, so you don't need to dwell too much on the kidneys. but they are very important, involved in the skin, of course, and the teeth. So really the entire body can be affected. So with all of that background, kind of the multi-system involvement affected by calcium and PTH, what are some of the symptoms? When I use the word symptom, I just want to remind you that I'm talking about what you will feel or what you will show. I'm not talking about something nebulous. It's something that you report to us. So the symptoms. One of those symptoms of a low blood calcium is tetany. And that means the muscles are irritable. And I've got some pictures to show you, and I think you could all tell us what that's like because so many of you have had that. A seizure, we mean there a fit or a convulsion, and there are several kinds that can occur when the blood calcium gets dangerously low, and we definitely consider that a very significant complication of hypocalcemia. I've mentioned anxiety, depression, poor memory, brain fog. These are all symptoms of effects of calcium on the brain and brain function. Then bronchospasm, which is an effect of a low blood calcium on the muscles within the lung and within the upper airways. So you can have wheezing and throat tightness, like laryngospasm is what we're talking about there. And you might feel a choking sensation in your throat. Then the muscle cramps, of course, which often go with the tetany, and then that numbness and tingling, particularly in the hands and the feet, around the mouth and in the lips. Those are areas that are particularly ones where those particular symptoms occur. And then the kidney function we've talked about. And then rarely does the heart get involved, but again, it often means it's a chronic problem and it's not being addressed by the treatment that people are getting. So those are the main symptoms of the low blood calcium and the due to hypopara. So as I said, I wanted to show you some pictures of tetany, and these are taken from the internet, so you can probably even find them if you do some searching. But tetany comes from the muscles being hyperexcitable, okay? And they're hyperexcitable because the nerves are stimulating them excessively, okay? And there are other reasons other than just calcium for tetany, but this is the main one that we're talking about today. And it's an involuntary contraction. Your fingers cramp up. The claw deformity or the claw-like hand that people get is a manifestation of tetany. And you can certainly see that in situations of low magnesium as well. So those are just some pictures of how the hand can appear when tetany is in place. So let's turn now to the thyroid, just some facts about the thyroid. You know that it is right in the same location as the parathyroids are, much, much bigger, as you can see. And its job is to make two hormones, T4, thyroxine, and T3, triiodothyronine. Important to realize that T4, that's the one that the thyroid makes the most of, is what we call a prohormone. In other words, all the tissues that use the thyroid hormones tend to make their own supply of T3, and that's the one that is most active in our tissues, okay? And in the thyroid gland makes some T3 directly, but most of it comes from the peripheral tissues. So this is just some additional physiology about how thyroid hormone is regulated in our bodies. And I wouldn't go into this if it weren't important, because many times we are confronted with measuring different hormones and assessing the thyroid status of a person. And the reason for that is illustrated here. So the things that control thyroid hormone production by our bodies, or that reflect how our bodies are or are not sufficient in thyroid hormone, is this hypothalamus pituitary thyroid axis. And as you can see up in the top, the hypothalamus, it's a part of the brain, and it produces a hormone called TRH, or thyrotropin, and the other word for thyrotropin is TSH. produces thyrotropin-releasing hormone, which travels down to the pituitary gland. They're right there in the same place, travels down to the pituitary gland and causes it to make TSH, or thyrotropin. And the pituitary makes that, and then that goes to the thyroid and causes the production of thyroid hormones. And this production is very, very carefully regulated by the level of TSH in our bodies. And you can see those arrows that feed back on, going back up from the thyroid to the pituitary and to the hypothalamus. So this is what we call a classic negative feedback loop. And the thyroid hormone that is produced by the thyroid gland, or that you take in the form of pills, feeds back on the pituitary. And the pituitary has a level of thyroid hormone production or thyroid hormone supplementation that it wants for your body. So it's a very, very good thermostat, if you will, of thyroid function. So if the T4 and the T3 levels are high and they're too high for your body, the TSH level is going to fall. That's negative feedback. It's going to lower those levels. If the T4 and the T3 levels are too low, then the TSH level is going to rise. So when we do those blood tests, looking at thyroid function, we are going to measure the T4 and we're going to measure the TSH, and they're going to be excellent indices of what your body wants your thyroid status to be. So this is how we tell what's, as I say in the bottom of this slide, what's normal in the right range for you. So what does thyroid hormone do in our bodies? It's got a huge number of functions. Nearly every tissue, I really think every tissue in the body is affected by the level of thyroid hormone. So very, very important as calcium is in our bodies. Thyroid hormone affects metabolism, it affects growth in childhood, it affects brain development in babies and children, and it has very specific effects on our heart, our muscle, our kidneys, our liver, our skin, everything's affected and responds to thyroid hormone. So it's critical that the level of thyroid hormone that you have in your bloodstream is good for all of these tissues. A few words about the heart, okay? Because sometimes when thyroid hormone levels are way out of line, you may be feeling some of these effects, and I want to bring those symptoms to your attention. So if there's too much thyroid hormone in the body, your blood pressure may go up. Your heart rate may go up. The force that your heart is contracting with when it beats may be stronger than it's capable or comfortable contracting with. So you may tire out. Even if this isn't addressed by someone, your heart could enlarge and even heart failure could occur. If the thyroid hormone level is too low, that may slow down the heart rate, may lower the blood pressure. And so we can pick up these things when we check your vital signs in the clinic. And even when thyroid hormone is at a low level, and it may go on for a long time, you can get heart failure from that. So it can be a confusing picture, but thyroid hormone is very important for the function of our heart. Lungs, it's really important as well because thyroid hormone can feed back on centers in the brain that control our breathing, so important there. And not only heart rate can go low, but respiratory rate can go low if thyroid hormone levels are too low. In addition, thyroid hormone regulates the motility of the intestine. And if the levels are too low, you may experience constipation from intestinal hypomotility, low motility. So it's important there as well. In addition, thyroid hormone is really important for the bone. It regulates sort of the overall metabolic activity of bone cells. And if the levels of thyroid hormone are too high, so the T4 level is too high, and then the TSH level gets suppressed, that's the picture we'd be looking at there. You may experience loss of bone mineral density. And this is really important, particularly in women who are after menopause, where bone loss from estrogen deficiency is a very important consideration. So we want to pay very close attention to what the thyroid hormone levels are in everyone, but also particularly in women who are postmenopausal. And so you may hear your doctor say, I want to make sure the thyroid hormone replacement is just right because it may contribute to osteoporosis. So that's where we're coming from with regard to that. It's very important for bone cell function. And then, along with what we said already about calcium and the brain and the muscle and the nerves, thyroid hormone is also really important there. If there's too much thyroid hormone in the bloodstream, the muscles can fatigue faster, you can feel weak, may have trouble getting up, may have trouble getting around and exercising. In terms of the nerves, thyroid hormone, if there's too much of it in the system, you may experience a tremor or jitteriness or hyperactivity. And then if there's too little, it's sluggishness and tiredness and muscle aching and things like that. So really, really important for nerve, muscle. And then in terms of the brain, if thyroid hormone levels are too low, for example, you may not feel as alert as you normally would, and as functional as you normally would. So very important for all of those functions. As I said, in childhood, very important for the growth of children, may affect brain development, and in women with too little thyroid hormone over time can have problems with their menstrual cycles, irregular periods, heavy bleeding, and sometimes difficulty getting pregnant. So very important for really literally every system in our body. So what are some of the symptoms that you might experience if your thyroid hormone levels are too low? Hypothyroidism, right? That's what we call that situation. So fatigue is one, tiredness, being sleepy, particularly like in the daytime, sleeping excessively, memory and concentration can be affected, weight gain can occur, the muscles are weak, we've talked about it, constipation because of the effects of inadequate thyroid hormone on the gut, dry skin and dry nails and dry hair. I didn't really mention that, but the hair and skin need thyroid hormone to be healthy as well. And then fluid retention. So there's quite a bit of symptoms that you could potentially experience because of low thyroid hormone levels. So now what I've done on this slide is I've tried to line up some of the most common symptoms on your left in the blue of hypothyroidism, and over here on the right of hypocalcemia. And you can see for fatigue, both situations can cause fatigue. For sleepiness, if someone is complaining of that, I'd be thinking more of a thyroid problem. Poor memory, poor concentration, brain fog, it really can be both. Okay, so we know, we can see already there's plenty of overlap and there's plenty of challenge for us and for you to distinguish what symptoms are coming from what problem, right? Weight gain, that's going to be more hypothyroidism. Muscle weakness, it's going to probably be either. Okay, constipation, mainly the thyroid, the dry skin, the hair, and the nails, mainly the thyroid, the fluid retention, mainly the thyroid. But then if you look on the right, when we started talking about tetany and muscle cramping and numbness and tingling, that we're going to lay at the doorstep of hypocalcemia and hypopara. So there's some overlap, as you can see, not that much, but there is some, and that overlap is important. But most of the time, when we kind of get to know you better and your symptoms better, can figure out which situation. And of course, we use the blood test to guide us in making those decisions. So when we're monitoring thyroid hormone replacement, I think the first question is always, how do you feel? Do you feel like your energy is up to par? Do you feel well? What's new with how you feel? And then I usually run through the symptoms of hypothyroidism or hyperthyroidism quickly, just to get a pulse on how my patient is feeling. And then we turn to the lab tests because those are going to be so very, very helpful. What is the free T4? Is it in the normal range? Is it where I want it to be? And where is the TSH, right? That important negative feedback loop is so critically important when we look at these lab tests. So I want that TSH to also be in the normal range. Now, I know some of you with a history of thyroid cancer have a different acceptable normal range. So we have to look at that in the context of your own situation, but we've got to look at both at the same time. And then I think the other important thing to remember is that if a small change is made, or even if a big change is made, you don't want to be doing lab tests for thyroid with, any faster than 4 to 6 weeks. So 6 weeks is sort of a sweet spot. And so you want to look at those lab tests because it takes a while for that whole negative feedback system that we talked about, takes a while for that to, reset itself and give us blood tests that we can take action on and that we can rely on. So remember that about thyroid hormone. We're not going to be measuring it instantly a day or two after you make a change in the hormone. Now, we often get the question, why am I taking this particular amount, or do I need an adjustment in the amount of thyroid hormone that I'm taking? And you can see here, this is a table from a publication just telling us kind of a guidance, if you will, for how much thyroid hormone replacement people need. And so age is very important. And you can see with every single recommendation about thyroid hormone, we're looking at what the body weight is. And you can see in the middle, I've kind of highlighted the fact that for adults, we're looking at about 0.7 micrograms per pound or 1.5 micrograms per kilogram. That's the usual replacement. So if you've had a thyroidectomy, you're going to be thinking about, that particular range of thyroid hormone replacement. And then after that, it's fine tuning. Okay. And in older people, we lower the amount of replacement so we don't overstimulate often. And in pregnant women, we have to give more because of the needs change in pregnancy. So as you can see, there's lots of factors that go into it, and we need to be conscious of those factors, not just at age, not just weight, but all of the factors involved. And then, of course, we have the lab tests to guide us. Now, hypoparathyroidism, same kind of thing. You start with how you feel. And I usually start with the symptoms of hypocalcemia because those are really the scariest for you to experience. We want to know, are you experiencing those? The tetany, the muscle cramping, the numbness, the tingling. And then we go to the lab. Now here that we know calcium changes from moment to moment, so we're only going to get a snapshot of these lab tests, and they may not correlate with what you're experiencing at home or when you're exercising and so forth, but it's the best we can do at this point. And a good picture of the lab could involve really everything I've listed on this slide. But most of the time we're looking at the calcium with an albumin and with a phosphorus to kind of determine, okay, have we got good control of the blood calcium level? And are these symptoms due to the fact that the calcium's, being run at a level that's too low? Now, different from thyroid here, when we make a change, like we say, okay, you need to take a little bit more calcium in the middle of the day. When we make a dosage adjustment in either calcium or calcitriol or even PTH, if you're on that, we usually wait 1 or 2 weeks before checking the labs. You can do it more frequently if it's kind of an urgent situation, but in general, we're doing it fairly promptly after we make an adjustment because this is a much more dynamic system than the thyroid and needs to be checked more frequently or more close to the time when you make the change. So I just wanted to end with just some suggestions. I don't think I've resolved the challenges that it can be for you to decide what your symptoms are due to, and for us to decide often when we're trying to, get the best outcome and get you feeling at your best. But here are just some kind of general recommendations that I use all the time. And I call them tipsifications. Is just the beginning. It's the recipe for trouble. Okay. Remember to spread out the calcium you're taking so you can maximize the absorption. Taking, 3 grams of calcium once a day is just never going to work well. It's much, much better to spread it out over the course of the day if you can. You want to take your thyroxine, your T4 on an empty stomach if that's at all possible, and then wait an hour before eating, again, if that's possible, just so that you can get good and consistent absorption of thyroid hormones. You want to take any supplements that you're taking, and you need to look at your supplements that have iron or calcium in them, at times different from your thyroid, because you can get an interaction that lowers the amount of thyroid hormone that gets absorbed, and that can lead to lab tests that are troublesome and difficult and symptoms for you as well. Remember that some of the foods that we take in have calcium in them, like calcium fortified orange juice. You don't want to take your thyroid hormone with that kind of an orange juice, for example. And then same with antacids, okay, if you're taking those. And then if you're taking a high fiber diet, because that can actually affect calcium thyroid hormone absorption, you want to make sure that you just sort of be as consistent as you can about the fiber intake in your diet. And then I think one thing that's particularly important with regard to thyroid hormone is to look at the prescriptions when you get them refilled and make sure that the thyroid hormone that you're getting is the same generic brand. There are, I think, 6 different brands now for thyroid hormone, and you want to make sure that you're not getting switched around because there can be differences in bioavailability with different preparations, generic preparations of thyroid hormone. So you can take a look at that, see which formulation you're getting and make sure it's consistent, and ask your pharmacist not to make any switches because sometimes that can happen without our even knowing about it. Okay, so stay with the same brand if you can. I think it's really important that, you know, if you're experiencing symptoms at home that you're wondering, is it low calcium, is it low thyroid, mark down what's bothering you and bring those questions, bring those dates, and bring that to your medical appointment so that we can kind of try to work this out together. And then if you're taking any new medications or new supplements, bring those in and bring in more pictures of the labels, for example, so that we can go over those and make sure there isn't something in that supplement that's affecting either your blood tests, and that's well known now, like supplements like biotin, for example, can definitely affect thyroid blood testing. And I think it's critically important to, you know, if you're introducing something new into your medical regimen, to let your physician or healthcare provider know that. And so just the final things, we're in this together, we always are, and we want you to feel your best. So really, let's work together on making things work well for you and work much better. With that, I think that is my last slide.
All right, let's give it up for Dr. Schoback.
And we'll take questions.
Thank you so much. And we're going to take some questions from the audience first. Bob, do you have the microphone? Okay. I think Bridget raised her hand.
Hi, Dr. Schoback. I got a question. Do you have a list of the types of seizures that we could have, the names of them by any chance?
That information is in a lot of the publications, and I would say right off the bat, you would be talking about kind of a seizure where you lose consciousness. We call that a generalized seizure, a grand mal seizure. You can also have what are called petit mal seizures, probably even focal seizures where just one part of the body would shake or something like that. And probably even what is often called an absence seizure. So there's the potential for really any of the neurologic spectrum that are called seizures to take place, but those are the most common. And in one of the publications I mentioned to you yesterday, we have a very nice section of that on the neurologic manifestations. And so Patty and I are going to work on making sure that those papers get onto the website. So that would be a place to take a look at that if that's it.
Thank you, because they didn't have that information back in 2004, and I would say I had more of the shaking one, and at one point I had the more severe one when I was younger, but they didn't understand it then, so thank you, it just confirms.
Oh, Bob, over here.
So just to clarify, if you don't have a thyroid, you're still getting the TSH and the T4 every time that you get your thyroid checked?
Guilty as charged, I do. And the reason that I do that is that some of the time I wish I had it. Many doctors will just measure the TSH and say, okay, it's fine. And there's nothing really wrong with that. But about a half to a third of the time, you wish you had the free T4. And so I generally just get it. I have to be honest. But you could mostly use the TSH because it is such a precise barometer of what your body wants and needs, and skip the free T4.
Thank you. Michelle?
Yes. Have a patient has increased free T4, but an in-range TSH and no thyroid. What would cause this?
It would, I mean, since it's coming from the supplement, since the thyroid has been removed, what would cause it would be the amount of supplement that someone is taking. And it would say that that amount of thyroid hormone is okay with that person's pituitary gland. If you've made an adjustment more recently, for example, like, I mentioned how you want to wait that 6 weeks if you can after each adjustment. So like if you've up titrated, increased the amount of thyroid hormone, and the thyroid hormone level has gotten to a higher level perhaps than you want it to be or outside the normal range, the TSH might not have caught up, if you will. So those would be two quick explanations for why that might happen. But I think over time, all of us use the TSH as the best indicator of what's going on with the individual and where the body is happy with the amount of TSH. Occasionally, you find that the TSH and the T4 are disconnected, and that could be situations where the pituitary gland is also involved. Remember the hypothalamus and the pituitary. That's really pretty rare. Most of the time, it's all going on in the thyroid and the pituitary by itself.
Thank you. Is there a relationship between your Synthroid dose and your calcium? In other words, when changing your Synthroid dose, does that impact the hypopara symptoms?
Ooh, what a good question. I would say generally no, because I'm hoping that you're not asking the question because someone has, severe hypothyroidism and untreated hypopara. When you get at the extremes of both of these conditions, treating one can certainly affect the other, when things are really out of line. But most of the time when you're making slight changes, you don't have to readjust the calcium, for example, because you're, lowering the thyroid hormone dosage or raising it a little bit. But of course, if it's a brand new situation and the calcium is very, very low and the thyroid is very, very low, you could certainly have an interaction there with the muscles and the heart and many other things. So you want to attack the situation, make things better with regard to the blood test, and then kind of reassess. But usually, you're kind of able to adjust each one of these meds independently.
Okay. The next question is, have you seen patients that need to run slightly outside of normal levels on their TSH because they feel well at those levels, and when their TSH is normal, they have hypo symptoms?
Yes, I think I have. I have to be very careful in those situations about allowing that to happen, because kind of as we went through the different organ systems, you can see that over time, that could be a bad thing for body systems that don't, give us symptoms, like, for example, the bone. And so if a patient says to me, I feel so much better when my free T4 is 25% higher or 20% higher than the upper limit of normal, and my TSH is low, because even though you might feel better, that could have a detrimental effect on your bones. It could have an effect on the heart and cause atrial fibrillation. So we have to do our best to hold the line in those situations, because we know that some of the downstream consequences of running a high free T4, for example, even though you might feel better, it might be a regrettable situation if you go into atrial fibrillation, for example, or develop osteoporosis or worsen bone loss. So there are things that are silent until they become a problem. And so we have to be very careful and use the laboratory and work together on this, because We don't want those untoward side effects of over replacement, for example, or over supplementation to cause trouble down the line.
Okay, and I have
One
another
more.
question. There seems to be some disagreement on when to add T3. Do you have any recommendations?
I don't use a lot of T3. It's a big question that comes up. You're totally right. It's a good question. I don't use a lot of it, and I think many of us don't, because when you think about it, why does the body have a system where it converts T4 to T3? It's because, you know, the heart is smarter than we are. The liver is smarter than we are. The brain is smarter than we are. And they will make the amount of T3 that is healthy for those cells. And so we have to be careful. So when we give the T3 by itself, we are, avoiding all those important control points that our body has in place for regulating the amount that the heart sees and that the liver sees and so forth. So we do it with great care. Occasionally we do it, when people feel there's a gap, and so occasionally we do it, but with great care. So yes, it's a question. It comes up, and sometimes we do it with, as I said, with great care.
All right. Well, thank you so much, Dr. Schobach, for both of your presentations were amazing. Thank you.
Bye-bye now.
Bye.
Have a great meeting.
All righty, so we're going to move along, and we're going to see a presentation from Dr. Mark Summeray. He's been in the pharmaceutical and medical devices and biotech industries in the U.S. and Europe for the last 23 years. Currently, he is the Chief Medical Officer at Amolyt Pharma. So let's see what Dr. Summeray has to say.
Good afternoon, everybody. My name is Mark Summeray. I'm the Chief Medical Officer at Amolyt Pharmaceuticals. It's a pleasure to be with you today, and thank you to the HypoPARAthyroidism Association for the opportunity to present an update on eneboparatide, our progress in development, and our phase 3 Calypso trial. So for those of you that may not be familiar with Amolyt, we are a biotech company that is focused on developing new treatments for rare endocrine and related diseases. And our goal through the development of these new treatments is to transform the lives of patients suffering from these conditions. This slide shows you an overview of our pipeline. If you look at the top of the slide, you see eneboparatide for hypoparathyroidism. That's obviously going to be the focus of my presentation to you this afternoon. But just to point out that we also have some other products in development, one for acromegaly, which is also a rare endocrine disorder, and further back in development, still early on in the laboratory, we're working on some new treatments for hyperparathyroidism, the opposite issue to hypo, so where there is an overproduction of parathyroid hormone, which can happen in relation to a tumor or in relation to other cancers. And these two areas, acromegaly and hyperparathyroidism and humoral hypercalcemia of malignancy, are both also areas that Amolyt is focused on. But as I mentioned, today we're going to talk about eneboparatide, which is an agonist at the PTH1 receptor. So this is the structure of the peptide. A peptide is simply a sequence of amino acids. And you're probably all familiar with a protein. A protein molecule is simply a much longer sequence of amino acids. A peptide is really just a short protein. And eneboparatide, which is also sometimes called AZP3601, is a sequence of amino acids, 36 amino acids long. And it's actually synthesized by chemical synthesis in the laboratory. And it's very similar in structure to naturally occurring parathyroid hormone and a related hormone called parathyroid hormone-related peptide. And the scientists that designed this molecule did so by taking certain sequences of amino acids from both of these naturally occurring hormones and joining them together, and then making a few changes to the sequence, just substituting some amino acids for others. And these amino acid substitutions are all so-called naturally occurring amino acids. And in the process of doing this, they've generated a peptide which will bind to the parathyroid hormone receptor in a very special way. And so in order to explain this, we've created a video which we're going to show you now.
Hypoparathyroidism is a rare endocrine disease characterized by parathyroid hormone, PTH, deficiency. Without PTH, normal blood calcium levels cannot be maintained because the kidneys are unable to reabsorb calcium, the intestine is unable to absorb dietary calcium, and bone turnover stops. Low blood calcium levels cause a variety of recurring symptoms. On average, most patients experience 16 symptoms per day, lasting 14 to 16 hours, leading to a reduced quality of life. Simply treating with PTH 1 to 34 or 1 to 84 peptide injections is not optimal because the effect is too short. PTH binding to the PTH1 receptor triggers the binding and activation of a G protein, initiating the biological effect. Upon G protein release, the receptor assumes a different conformation known as R0. Because PTH binds weakly to R0, it is rapidly released from the receptor, ending signaling. Consequently, PTH action lasts only as long as its short blood half-life and cannot provide 24-hour symptom control. Prolonging PTH in the bloodstream may allow sustained normalization of serum calcium levels and symptom control, but has been shown to cause significant bone loss and may not normalize elevated urinary calcium in all patients. Like PTH, the investigational drug eneboparatide is a peptide made of natural amino acids that binds to the PTH1 receptor and has a short blood half-life. However, eneboparatide is uniquely designed to bind tightly to the R0 conformation of the PTH1 receptor. As a result, when the G protein is released, eneboparatide remains bound, allowing multiple rounds of G protein binding and signaling, thus producing a long effect. This prolonged activation of R0 by eneboparatide is designed to restore normal calcium reabsorption and vitamin D production by the kidneys, which may allow continuous maintenance of blood calcium without supplementation or bone loss. Through its unique mechanism, eneboparatide is designed to maintain normal blood calcium for a full 24 hours to better control symptoms and improve quality of life.
So just to explain a little further, having seen the video, of course, the most important thing is to understand how eneboparatide actually behaves in the clinic. In other words, how it behaves in humans when we measure its effects. And this slide is showing you two things. First of all, on the left side, how the eneboparatide, how the peptide has a very short residence time in the blood. It has a short half-life. And on the left side, you can see that after different doses are injected just once, there is a very rapid clearance of the peptide from the bloodstream, so that after just 2 hours, it's no longer possible to detect the presence of eneboparatide. And then the graph in the middle, as well as the graph on the right, shows you the effect of a single injection in the middle and multiple injections on the right of eneboparatide on the calcium levels in the blood. You see the middle graph shows after a single injection of eneboparatide, there is a rise in calcium levels, which lasts for at least 24 hours at the higher doses. And the same observations are made after multiple dosing once a day of eneboparatide in the graph on the right side. Now, the data I just showed you were generated in healthy volunteers, healthy human subjects, but of course it's even more relevant to look at data in patients with hypoparathyroidism. And the graphs you're looking at here show the results of our phase 2 study with respect to a reduction in the dose of active vitamin D or calcitriol after patients were started on eneboparatide. Across the bottom axis, you can see time from day 1 to day 84. And the results have been divided into 2 graphs because we had 2 separate cohorts of patients. On the left side, you can see after 14 days, the average dose of active vitamin D came down dramatically, almost to 0, after eneboparatide had been administered for 14 days. And the same observation on the right side in the second cohort of patients. And over longer treatment periods, out to the end of the 84-day treatment period for the study, the dose of calcitriol was reduced to 0 in almost all of the patients. There was only 1 patient in each cohort that was still taking calcitriol. And we also made the same observation for calcium supplements. So as you are all no doubt aware, calcium supplements are given to patients with hypoparathyroidism in order to try to maintain calcium levels in the blood that can make sure that we avoid the symptoms that are such a distressing part of this condition. Once eneboparatide treatment has been started, you can see in a similar fashion to vitamin D, we see a rapid reduction in the average dose of oral calcium, such that by the time you get to the end of the 84-day treatment period, almost all of the patients are taking doses of oral calcium supplements well underneath that horizontal orange dashed line, which is the dose of oral calcium that represents the difference between just a supplement dose and what's considered to be a therapeutic dose, which is 500 milligrams or more. So what we can see from these data, that once eneboparatide treatment has been started, patients are able to discontinue the supplements very quickly. And of course, it's also important to see that eneboparatide treatment is capable of allowing the blood calcium levels to be controlled within the desirable range. And in this phase 2 study, the desirable range was given to the doctors as between 7.8 and 9 milligrams per deciliter, the range that's shown between the orange dashed lines there. And in both cohorts of patients on treatment with eneboparatide, the blood calcium levels were maintained successfully within this range, while at the same time the supplements were withdrawn. Another important goal of treatment for hypoparathyroidism patients is to normalize the amount of calcium that's present in the urine, because we know that higher levels of calcium in the urine than normal results in injury to the kidneys over many years as a result of kidney stones or deposition of calcium salts in the kidney itself. So we're very happy to see that on treatment with eneboparatide in this phase 2 study, we saw a rapid reduction in urinary calcium, so that after just 14 days, the average urinary calcium level is below the upper limit of normal. So we've normalized urinary calcium, and you can see that the levels continue to decrease in both cohorts of patients through to the end of the study. And this is a very important observation because it's such an important goal of treatment to normalize urinary calcium in patients with hypoparathyroidism. We also focus on bone safety. And what we're measuring and showing you in this slide are chemicals or markers that we can assess in the blood that reflect how much bone turnover there is. And turnover means how much new bone is being formed versus how much old bone is being broken down. And normally, in patients or individuals who do not have hypoparathyroidism, we always have some degree of bone turnover happening where old bone is broken down and replaced by new bone. But in the absence of parathyroid hormone in hypoparathyroidism, this process tends to decrease dramatically so that old bone accumulates and it isn't broken down and replaced by new bone. So once we see treatment here with eneboparatide, what we're looking at is an increase in these markers in the blood, which reflect both bone formation as well as bone breakdown or resorption. And the encouraging element here is that the magnitude or the degree of rise in both of these biomarkers is quite similar over the 84 days of treatment. And that means that we're seeing a balanced increase in turnover. In other words, we're seeing a rise in both bone formation and bone resorption, but one is not dramatically greater than the other. And that's a more physiological situation and suggests that over longer treatment with eneboparatide, we wouldn't expect to see bone loss. You would actually expect to see some bone turnover, but a fairly stable situation with respect to bone. And we think this is an important observation, particularly in patients who may be postmenopausal females, because of the risk in postmenopausal females of a decrease in bone mass, a condition that sometimes is usually referred to as osteoporosis. And so therefore, we think that bone safety with eneboparatide is an important element or feature of this peptide. So to summarize the data that I've just shown you in patients, we've seen a good safety profile with eneboparatide administration. We have not seen any serious adverse events reported with treatment. And none of the adverse events that were reported in our clinical studies were of severe intensity or resulted in discontinuation of the drug. We also have seen the ability to maintain normal levels or target levels of blood calcium while withdrawing the supplements, which is very encouraging. We also saw normalization of the amount of calcium present in the urine and an effect of eneboparatide on bone, which is suggestive of a restoration of a balanced or physiological bone turnover situation. So with all of that said, we have the data we need to move into a phase 3 study or a pivotal trial, which has just started, actually, including centers in the United States. And this is the design of the phase 3 study. The study has defined different endpoints, which are methods of assessment of the efficacy of eneboparatide in treating patients with hypoparathyroidism. The primary or the most important endpoint is the proportion of patients who achieve control of blood calcium levels within the normal range, while at the same time achieving independence from their supplements. But in addition, we also have some secondary endpoints, which are also very important. The first one is normalization of the 24-hour urinary calcium levels in patients who start the study with elevated levels of calcium in the urine. And then we have a number of secondary endpoints which are focused on the assessment of the impact of treatment with respect to the symptoms of the disease and impact of the condition on quality of life. And then in addition, we have some safety endpoints which include bone safety. For the reasons that I explained just before, we think that bone safety is a very important component of treatment of this condition. And we're going to be measuring the biomarkers or the chemicals that I mentioned in the previous slide. But in addition, we're going to do DEXA scanning, which is a way of assessing bone mass over time. So how much bone mass the patients have on treatment. as well as an additional imaging method which uses CT scanning to measure bone quality. And you can see at the bottom there the design of the study. We're going to enroll enough patients so that we can randomize 165 patients in a 2-to-1 fashion, meaning twice as many patients will be randomly allocated to receive eneboparatide as placebo. And then there's a 24-week period during which patients will be either treated with eneboparatide or placebo. And then at the end of the 24-week period, anybody that was on placebo will be crossed over to receive eneboparatide, so that all patients will be on the drug for the next 28 weeks to the end of the study protocol. And we do plan to have an extension study beyond the end of this Calypso trial, which would keep patients on treatment, and patients who are doing well and benefiting, as we hope they will be able to stay on the drug probably for at least another 2 years, or indeed, if the drug is ultimately approved, until that happens. Here you can see the distribution of clinical sites. We have a number of centers in the United States. You can see those represented on the map, as well as mostly in Western Europe and also in Australia. So we actually have 63 sites participating in the study, and 18 of those are present in the US. We also have 3 sites in Canada. Here is a list of the sites, as well as the principal investigators. On the right-hand side there, you can see in bold. You probably recognize many of the doctors that are listed here. These are physicians who are participating in the study and supervising the patients together with the other staff at the sites. And I mentioned also we have 3 sites in Canada as well. You can see these listed here. So I'd like to conclude with just a few remarks. First of all, as you've seen, eneboparatide is showing some promising data from the early phase clinical trials. The data that we have suggests that eneboparatide has the potential to control blood calcium levels while at the same time allowing patients to discontinue their vitamin D and calcium supplementation. And we've seen that eneboparatide treatment is associated with a rapid normalization of the amount of calcium that's present in the urine, as well as having a balanced or neutral or physiological effect on bone. And as I've just shown you, we have a phase 3 study, which we also call a pivotal study, that is underway and enrolling patients in the United States and Canada. And we expect to finish the enrollment for the study in the first half of next year. So with all of that said, I'm now going to be available to participate in a live Q&A session and be very happy to address any questions you may have. Thank you very much.
All right. Thank you, Dr. Summeray. And questions in the room first?
Okay, I have one online that says, how long is the washout period for PTH replacement, such as coming off of Forteo or not para for this study?
3 months.
Is there any limit on calcium or calcitriol dosing or changes leading up to the screening visit?
No, we just have some minimum requirements, meaning that we need to be taking over a certain amount, more than a gram of calcium supplements per day, and also over a certain amount of vitamin D supplementations, but there isn't a maximum.
And does eneboparatide have any impact on lowering phosphorus?
Yes, it does. Yes, so we've seen the effect of eneboparatide on phosphorus in particular in the first few hours after dosing. So yes, we would expect to see some potentially beneficial effects on the levels of phosphorus in the blood.
Okay. Michelle, do you have one before? Okay. Got another one for you.
Hi. Oh, is there someone else?
Go ahead.
Hi, I was wondering if you've looked in any of your studies so far, if you've looked at how activity level is accommodated with your medication for high activity levels, such as gym workouts or days at an amusement park. Is additional calcium required with your drug?
So at this point, we've only done some relatively limited assessments of the impact of the drug on quality of life, using a very general questionnaire that captures some symptoms that reflect ability to function from a physical point of view, as well as how patients feel. And that early data is encouraging. As part of the Calypso study, which I've been talking about, we have a much more detailed assessment of all of the impacts of the disease on the patients in terms of signs and symptoms and quality of life. But to specifically address that part of your question about is it expected to have an impact on the ability to be physically active and requirements for taking calcium supplements, we certainly would expect to see an improvement in terms of how dependent you are on having calcium supplements available. We expect that requirement to come down quite substantially once on the drug. And we would also expect to see an improvement in general sense of well-being, ability to function, concentrate, the brain fog issue, which is often a problem, we would expect to improve, if not completely disappear. And we'll be looking to generate, or to collect, I should say, the evidence that would support that expectation. So certainly things that I think would enable people to exercise and enjoy activities to a greater extent.
Okay, thank you. Michelle?
Are there any patients with hypopara fatigue issues doing better on your drug?
Well, it's very early days. So all I can say is that anecdotally, we're hearing some encouraging commentary from some of the physicians who have started treating patients in the study. But I can't really give you any specifics so far because obviously we have to collect all of the data and analyze it. But I would say so far so good.
And then I have several people asking basically the same question. Can you do a little more explaining of why there needs to be a washout period for those that are on Natpara or Forteo?
Yes, so the reason for that, there's probably two reasons. First one is that we need to be able to only to isolate the effect of eneboparatide on the ability to control calcium levels in the blood, as well as withdraw the supplements, which hopefully will no longer be necessary once on the drug. And the effect of the drug on other things like the amount of calcium in the urine. So what we can't have is a background of other drugs that may also be influencing those things that we wish to measure that will reflect the action of eneboparatide. So we need to sort of remove any of those potential confounding influences on those really important measurements that we want to make, so we can very clearly see the impact of the drug. Apart from, there shouldn't be anything else to confuse the situation. And the other reason is that we want people to be in a very stable situation during the run-in period, so that their calcium levels are well controlled and their background supplements are not being adjusted all the time. So they're in a very sort of good place from a sort of stable situation before we start the treatment. Because then what we observe after starting the treatment is obviously only due to the treatment. It's not due to anything that's changing in the background. So obviously having other drugs that might be being administered would be a problem in that respect as well, potentially. So these are the reasons.
Okay, Dr. Kohlmeyer?
Yes, thank you. That was fantastic. I have a question and then just a couple comments because there's many of you that are in trials, and our U.S. site investigators are here. And we know that placebo doesn't work with hypopara, as we've shown in past 3%. So even though it's blinded, after a while, you know, if you're in a trial, if you're on parathyroid hormone. And so both with TransCon and AZP, my experience is amazing. I mean, patients talk about improved quality of life within days. You know, where are my fibromyalgia symptoms? I mean, what we've heard for the last 2 days, but for us, it's so rewarding. So I wanted to share that. One important thing for the AZP trial is to be off a thiazide for a month. And so that, you know, as a provider, worries me sometimes because I know your urine calcium is going to go up, but it's important. And then my question is the dietary calcium intake that, you know, you have to fill out the diaries and all that. You know, how detailed are we going to have that information in this trial? Because it's so important to know how much, you know, whether people have lactose intolerant or celiac, you know, because as their calcium supplements go down, I don't want them on no calcium, you know, and we know, and they know to stay on their D3, but they're almost all off active D. So I think that dietary calcium, do you know how detailed and how much information we're going to get in that regard?
Well, so first of all, I agree. It's really rather artificial to think only of calcium supplementation when there's such an important contribution from the diet. And as we know, dietary intake can vary. So it is being collected. I can't say, I have to be honest, about the level of detail that's been collected in the diary, electronic diary entry that we're using in this particular study. So I'd have to come back to you on that, Dr. Kohlmeier, but at least we are collecting some dietary calcium information.
Thank you.
Michelle?
Is there a chart that explains the similarities and differences between TransCon PTH and Calypso?
Just to clarify the question, is the question about the studies or about the drugs?
I think it from the way it looks, it's about the drug. Like, what's the difference between PTH and PTH-RP?
Oh, no, that's another question. So let me try and answer what I think the question is. So TransCon PTH is PTH 1 to 34. It's the important part of the PTH molecule that's been coupled to another molecule that gives the whole thing a very long half-life. So the approach is really to modify how long PTH is present after it's dosed so that you can get a much more even control of calcium levels over a 24-hour period between doses. And of course, it makes a lot of sense because we know that if you don't do that, if you don't make that modification, PTH itself or PTH 1 to 34 after it's injected, it doesn't stay around for very long. It's only a few hours. So this is really the basis and the logic behind TransCon PTH. In the case of eneboparatide, it's just a different way of addressing the issue. Instead of modifying the half-life, in other words, taking PTH and making it last an awfully long time in the blood, there's been some changes made to the individual building blocks that make up the PTH molecule. And these changes were done in a way to change the way that the eneboparatide binds to the receptor. The receptor is the way that the peptide achieves its effect. It binds to this protein on the surface of the cells, and then its effect results after that. And so what we've done with eneboparatide is change the nature of that binding between the drug and the receptor, and it results in a very long effect. So instead of changing the half-life of the drug, we've changed the result of the binding of the drug. So now, whether or not that turns out to be an advantageous approach, we will have to wait and see. But as you would have seen from the slides I presented, the data that we've generated so far certainly are consistent with what we were expecting to see. And I would say we have every reason to be optimistic about ultimately what we will demonstrate, which is what we hope is good control of calcium, ability to come off the supplements, particularly the vitamin D, and also bring down the calcium supplements, even if they're not totally eliminated, and control calcium and normalize urinary calcium in patients, because the high levels of calcium in the urine over a long time are a problem for the kidneys. So we think, we're seeing so far signs that eneboparatide is capable of doing all of those things to a very good degree.
Very good, thank you. And Bob, did you have somebody else?
So I'm wondering, and maybe you said this and I didn't process it, but if you're predicting improvement in kidney function or actually reversal, so like from CKD3 to CKD2 or better, or?
Well, that would be nice. I think, so that remains to be seen. One thing that we can measure very quickly is the amount of calcium in the urine. So that's point number one. Point number two is that it's generally accepted that high levels of calcium in the urine are not a good thing. And it's generally understood that the reason for that is because the calcium can cause problems related to stones that can form in the urine, and that in turn causes problems with the kidneys, as well as the calcium being deposited in the tissue of the kidney, and that's toxic to the kidneys over a long time. So if you think about the logic, it would certainly be a reasonable expectation that over a long period of time, if you're able to normalize the levels of calcium in the urine, so bring them down quite substantially, over a long period of time, you would certainly expect that any injury that would have occurred would no longer occur. In other words, we would hope to see stabilization. Would there be a possibility of improvement? Perhaps. But it would certainly take a long time for us to see that. And, we have to follow people on the drug for many years, and large enough numbers of those people actually, before we would start to generate the data that would suggest that perhaps we are having not only a beneficial effect on the calcium, not only stabilizing perhaps the kidney function, but maybe even doing what you just suggested, which is improving people in terms of the category of renal function measured by their filtration rate, seeing it improve. It's a possibility, but it'll be a long time before we see that.
Okay, thank you. One more question?
I have one online that says, how would you reverse this molecule's effect if there were a need to, i.e. if a patient was starting to go hyper?
Well, the good thing about the drug is that it has a short half-life. That means that if you stop dosing it, then you will see that it's gone very quickly. Now, of course, as I already explained, when you dose it, it has a long effect. By that, I mean, after a single dose, the effect lasts for 24 hours or more, maybe up to 48 hours. So in this situation where the calcium's too high, the most likely thing would be to simply decrease the dose. I think the important point to make here is that each patient's treatment with the drug is very carefully adjusted so that as the supplements are withdrawn and the patients are started on the drug, there's a titration, an adjustment of dose over time, so that whatever is the right dose for that patient, it's achieved over time according to the result, which is really the monitoring of the blood calcium levels. And this is done by the doctors who are very closely monitoring what's happening with the calcium and adjusting the dose accordingly. In the unlikely event, and of course it can happen, that calcium goes too high, it's always possible to lower the dose, and we would expect to see the result of that lowering relatively quickly in the next 2 or 3 days. So it ought to be a matter of adjustment of dose according to calcium response, and it's a relatively quick relationship between the two.
All right, one more.
Hi, can you speak more to the dose change specifically? Why you guys chose to go up and down by 10 instead of 5? Thank you.
Right. Yep. Well, I suppose the simple answer to that one is that each drug is different in terms of the relationship between any particular dose and the effect that you're trying to achieve. So that dose response relationship is different if we compare eneboparatide with other PTH type or like drugs. So it's not surprising, therefore, that the amount of the drug that you start at, which in the case of eneboparatide is a 20 microgram dose, that starting dose would be different from another PTH drug. And then the adjustments, the magnitude or the size of the adjustments are also different, up and down by 10. So that's the first point. The second point is the reason that we do that is because we've obviously very carefully studied that relationship, both in the laboratory and then in healthy subjects. And we've made predictions about what we should expect to see in terms of the relationship between dose and response. And then, as I mentioned, we've done a phase 2 study, and we looked at it there as well, because phase 2 is when you really fine tune whether or not you've got the right dosing for people. The good thing is, as I already mentioned, you can adjust the dose to suit the patient specifically. And of course, it's also true that you could adjust the dose by 5 if you needed to. It's not something that we always anticipate might be needed before we get into a phase 3 study. We would never dictate to any physician what they can and can't do ultimately in the best interest of the patient. So if a change of 5 is the right thing for the patient, then I think that's what the doctors will do.
Okay, well, thank you, Dr. Summeray. It was a wonderful presentation today. Thank you.
Thanks very much.
All righty, so we are going to take a break now until 2:30, so we'll see you back then. Thanks. All right, welcome back, everybody. We're happy to have you back. You know, in the beginning, I talked about where we have been to where we are today. And it's pretty amazing the amount of attention that we're getting now. Certainly we need a lot more attention as hypopara patients, but the attention that we've got in the drug companies, the pharma companies, the medical community has been amazing. So we have somebody new to us coming to speak to you today, and we're very excited. I want to introduce the president, CEO, and co-founder of MBX Biosciences, Mr. Kent Hollick is here to talk to you today about their company. Thank you.
Well, thank you for allowing MBX to participate in this wonderful meeting. It's really a pleasure to be here with several of my colleagues, and we've appreciated the opportunity to have met some of you, and I would just say that I continue to be inspired by your stories, your perseverance and dedication, which we see every day. It's a timely occasion to introduce many of you to MBX, as our lead program in hypoparathyroidism is transitioning from phase 1 to phase 2. So, see this clicker. By way of personal background, as you heard, I am Kent Harlock. I reside in Indianapolis. It is my hometown, but I haven't always lived there. Okay, after high school, I studied and worked in a number of places, including Prague, Hong Kong, London, New York, and Chantilly, which is a small town just several miles from here, coincidentally. And 21 years ago, I returned to Indianapolis to join a life science-focused venture capital fund, Twilight Ventures. And happily, another partner then was my MBX co-founder, Richard DeMarchi. And over the past 2 decades, we have collaborated on 4 successful biopharma startup companies. And it's just been a great opportunity to help patients and work with amazing technologies. I will share more about Richard and his interesting story in just a little while. Okay, but MBX Biosciences is a clinical stage biopharma company headquartered in Carmel, which is a suburb north of Indianapolis, formerly known as Bethlehem, turns out. Now, Carmel had one of the first automated traffic lights in the country back in 1924. And Carmel has certainly grown and changed a lot over the decades. And now Carmel is home to over 140 roundabouts, which is the most of any city in the US, staying at the forefront of traffic flow. It's true. So Carmel is also very well known for its quite successful girls swim team at Carmel High School, which has won 37 consecutive state championships. That is the most of any team in any sport of any high school in the country. And as cool as this fact is, I have to confess that I did not know it till I started preparing for this presentation. Okay, I mentioned my longtime business partner, Richard DeMarchi. And for those of you who are not aware of him, Richard is a leading light in peptide chemistry and drug development. He is a co-inventor on 100 US patents. He's in the National Inventor Hall of Fame. He co-authored over 250 scientific papers, but probably most importantly, Richard played crucial roles in the discovery of Humalog and Forteo, or you may know it as teriparatide. Now, of course, these 2 medicines have helped millions of patients across the globe. And that's not enough. Richard also invented the first GLP-1 GIP coagonist, which is the mechanism of action in an extremely efficacious treatment for type 2 diabetes and obesity called Mounjaro. Might have heard of it. And I mean, it's just a privilege to work alongside Richard as we bring forward innovative therapeutics in areas of unmet need. So I've shared a little bit about our founders and our hometown, roundabouts, and Now I want to share a bit more about our company and really what drives us every day. So MBX Biosciences was founded in 2019. We are a clinical stage biopharma company, and we're focused on developing peptide therapeutics that are transformative and to treat rare endocrine disease. We currently have about 30 people in the company, and well, here's some of them. So these are some of the people I get to work with every day, and as the pictures fill in, as you can see, what really drives us is helping patients. In fact, helping patients is our mission, specifically helping people with endocrine disorders live fuller and healthier lives by bringing to market innovative medicines. So I mentioned that we are exclusively focused in rare endocrine disease. So why is that important? Well, healthy endocrine system is essential to life. And with rare endocrine diseases, this disrupts the body's control of important bodily functions, blood sugar, growth, mineral balance, and bone health. And so, you know, we're focused on taking our innovative technology, our drug development expertise, and helping to make life better for people with endocrine disorders. So we work primarily in small proteins called peptides. You've heard a bit about them over the past couple of days. And whether or not people think about peptides, most of us are very familiar with one key type of protein, hormones. Hormones have crucial physiologic functions, helping us maintain homeostasis or dynamic equilibrium. And at MBX, we are developing peptide-based therapies that are designed to work better, last longer, and have fewer side effects than other medicines. So how do we achieve this goal? Well, we have developed world-class proprietary technology called precision endocrine peptides. And Richard DeMarchi has been optimizing this technology over a decade. And PEPs really seek to overcome the key limitations of native peptide therapeutics, okay, while harnessing peptides' powerful physiologic effects. So native peptide therapeutics have short half-lives, typically requiring frequent injections of supraphysiological or larger than normal dose levels. And the result is large fluctuations in drug concentrations over time, or peak to trough ratio, which adversely impacts patient outcomes. So think of when you have parathyroid hormone at higher than desired levels. Well, you have hypercalcemia often. Conversely, when PTH levels are below the desired range, symptoms associated with hypocalcemia can present. So in contrast, our goal is to achieve consistent drug exposure with infrequent injection. Or said differently, flat pharmacokinetic, or PK, profile, similar to continuous pump infusion, but without the inconvenience of a pump. So at MBX, we have a pipeline of PEPs, and these are in development to treat rare endocrine diseases, including hypoparathyroidism, also post-bariatric hypoglycemia, or PBH. So this is another rare endocrine disease. It's a chronic condition which can develop in patients following bariatric surgery. Our program in that area is in phase 1, in a phase 1/2 study. Okay, but let's talk about our lead investigational drug, MBX 2109. MBX 2109 is the first parathyroid hormone prodrug for HP with weekly administration. So, pretty excited about that. It is designed with our PEP technology to provide sustained PTH activity with a convenient subcutaneous dosing regimen. Now, PTH is an ideal target for our PEP technology because there is a narrow therapeutic range for PTH to maintain healthy calcium levels, as I referenced previously. Now, MBX 2109 is a precision endocrine peptide that is lipidated with 2 fatty acids. And these fatty acids facilitate binding to plasma proteins like albumin, extending time in circulation. Now, as a prodrug, MBX 2109 is engineered to be biologically inactive upon injection. And that's indicated by the red helical peptide on the left side of the cartoon here. Upon or under natural physiologic conditions in circulation, MBX 2109 chemically converts at a precisely controlled rate to active drug, as depicted in green on the right. This molecule binds PTH receptor and increases calcium in the blood. MBX 2109 provides sustained, predictable PTH peptide levels and convenient once-weekly dosing. And I'm excited that we now have demonstrated clinical proof of concept of our PEP approach with MBX 2109. So in fact, we recently presented our positive phase 1 multiple ascending dose results at the ASBMR meeting in Vancouver. As you may know, ASBMR stands for the American Society for Mineral and Bone Research. And the cover slide of our oral presentation is shown on the right side of the slide. And we were just delighted to share with the scientific community that our phase 1 study had achieved all of its primary and secondary objectives. So MBX 2109 is safe and well tolerated with repeat administration. Adverse effects were mainly related to mild redness at the injection site, which was self-limiting, infrequent, and not interfering with dosing. And also, to some extent, or secondarily, expected pharmacology of hypercalcemia asymptomatic at the highest dose levels. So importantly, MBX 2109 does have that flat PK profile, which was designed into the molecule with our technology, as I shared in the previous slide. So in other words, similar flat PK profile as continuous pump infusion. Active drug exposures were dose proportional, and steady state was achieved after 3 to 4 weekly injections. Additionally, the time action of MBX 2109 supports weekly administration or weekly dosing frequency. We believe this is a boon for HP patients. Besides providing greater convenience, we also hope for improved clinical outcomes, as has been observed in other peptide drug classes with once-weekly therapeutic options available. So lastly, the pharmacodynamic, or PD, effects of MBX 2109 reflect PTH pharmacology in healthy adult subjects. So as you know, PTH helps keep the right amount of calcium and phosphate in our blood, tissues, and bone. And so what we found with MBX 2109 is, as expected, in these study participants with intact PTH calcium axis, in fact, their endogenous PTH decreased. Additionally, there was a dose-dependent increase in serum calcium. So these safety, PK, and PD results support the advancement of MBX 2109 into a phase 2 study in HP patients. And importantly, they also affirm the intended product profile of weekly administration and flat exposure profile. So the FDA recognizes the needs of HP patients and that HP is a rare disease with limited pharmacotherapies. As such, the FDA has designated MBX 2109 as an orphan drug. Okay, so I am really excited to share that pending an upcoming meeting with the FDA, we will initiate a phase 2 clinical trial called AVAIL. And in the near future, we will be sharing details of the AVAIL trial and participating investigative site information on clinicaltrials.gov. We also intend to keep the HPA community informed about how you can participate. So what are we passionate about at MBX? Okay, I think you know this by now based on this presentation. You could probably get this question right in a pop quiz, but really what I wanted to convey to you all is that what drives us every day, what really gets us motivated and working hard is you and our dedication to serving the hypoparathyroidism community. So with that, it's really a pleasure to invite Danette Astolfi to the podium to join me. Danette is known to some of you as a member of the hypoparathyroidism community. I know her well as our Director of Program Management, and she's agreed to share some of her story with you. Thanks, Danette.
Thanks, Kent. Thank you. Well, the very first thing I'm going to do is turn my picture off because no one needs to see me twice. That's too much, Danette. But thank you. As Ken said, I joined MBX specifically for this program, and the reason I was so excited about this program is because I've been a member of this community for a very long time. I was diagnosed with hypoparathyroidism nearly 20 years ago, and as Patty said at the beginning of this, the world of hypopara looked very, very, very different 20 years ago. I'm not sure how many long-timers we have, but it was really a different world. We didn't have, all of this. And my diagnosis, it really took a long time, and once I was finally diagnosed and found an endocrinologist, it didn't really help that much. 20 years ago, most of the endocrinologists believed that you resolve the low serum calcium and all of your symptoms go away, and that was the treatment plan. You find your dose of calcitriol, and Tums, always Tums. I don't know who Tums paid to get so embedded into our treatment protocol, always Tums. But once you find the right regimen, you take it daily, and then you're good, right? That was the idea. Your serum calcium, you don't have any symptoms, you don't have any side effects, you don't have any long-term complications. And what won't surprise any of you is that that was not my experience. I continued to have symptoms, I continued to have variable calcium, and I went out, and again, 20 years ago, not that much information on the internet, but luckily I found the Hypoparathyroidism Association. And I began to connect with other patients, and I found that my story was very common. A lot of the patients said the same thing. Yes, I still continue to have variable calcium. When my calcium looks normal, I'm still having symptoms. And in a lot of ways, it was validating for me to understand what was happening, but on the other hand, it was very frustrating, right? All of us patients knew something that none of the doctors really seemed to know. And I was fortunate that a patient directed me to Dr. Rubin, who's still here, very many years ago, who spoke this morning, and she introduced me to the first NatPara trial. And when I began on PTH replacement therapy, I found that a lot of my symptoms resolved. And it was interesting because my lab work didn't look that much different from conventional therapy to NatPara, but I felt quite a bit different. And I was wondering, how do we get this to all of the patients? It was really a life-changing experience for me. And I was working in pharma at that time, but I was a chemist, and I was working on a very small piece of manufacturing process development. I didn't know that much about clinical trials. And it was because of the NatPara study I decided that that was going to be my new job, and I was going to figure out how to make it happen. And for the last 12, 13, 14 or so years, I've been working on developing, and working in clinical trials and drug development, specifically for rare diseases and unmet medical needs. It became very clear to me throughout this process that we had a disconnect. Patients were experiencing something. Physicians understood the disease in a different way. Researchers, pharma companies weren't always disconnected. Eventually, we all found FDA, as we talked about yesterday, way over here, completely on a different page than a lot of us. And I really wanted to be part of bringing all of that together. Right, good, dads. And that's why when I had the opportunity to join MBX and work on a hypopara drug, I was so excited about it. It really gave me an opportunity to work on my passion project full time. So I know we're early on in the process, as we talked about. We've not gotten to patients yet, but it was really important for me that we start to build relationships with the community, right? I think it's important for us to have that understanding early on and work together, right? We're all on the same side. We're all on the same team. We all want the same goal. And as so many people have said today, a lot of us know an awful lot about hypoparathyroidism, but every time we come to these conferences and every time we talk to another patient or another physician, we learn a little bit more. So while we've made so much progress in the last 20 years, not quite there yet. We've been talking about it over 2 days. We still have some progress to make. There's still room for us to grow. There's still gaps to be filled. And I really want, well, myself to be a part of that. MBX will be a part of that. All of you will be a part of that. And I'd really like us to start building that relationship and listening to you and listening to your stories, understanding the needs as they continue to evolve. And together, I hope that we'll do really great things and further hypoparathyroidism so that in 20 years, the world looks even better for us. So that's really all I have. I will add one more piece, which is that in the back outside, there's a whole lot of MBX merchandise. And if you don't take it, I have to pack it up and send it back. So please take bags and take notebooks and take all of that. But more importantly, throughout the rest of the conference, as we have some time, I'd really love to speak with you. There's some faces here that I've known for some time, a lot of new faces, which is great. But I'd really love to hear your stories and speak a little bit further. So with that, I will stop. As you know, those of you who know me know I could talk, and that Jeb just did this. So I will zip it now and leave some opportunity for questions as well.
All right, thank you.
Great, thank you, Dana. Don't go anywhere. We're going to help you with the questions.
Yeah, yeah.
Do we have any questions in the room? Whoop, back here.
I think it's quite exciting. You mentioned at the highest doses you didn't see any hypercalcemia in the folks who didn't have hypopara. So do you anticipate, I guess the question gets to what happens when you get hypercalcemia with this drug, how long does it last? Of course, you may not know this, but because you've not tried it much, so I just want to know what you're thinking about that.
Right. As I pointed out, the hypercalcemia, which was on target, occurred at the 2 highest dose levels, and it was asymptomatic, resolved quickly on its own, and did not, interrupt the study. And I think there's a feature of our prodrug, which is different from other prodrug structures, where our active drug, and you can see this in the cartoon. Oh, it's gone. But has the feature of being, extended time action. And there's accumulation over several weeks to steady state. So we kind of talk a little bit about an auto titration, slow, steady build to get to the maximal drug concentration. And so it'll be really interesting to see how this performs in patients. And, it's always hard to translate from healthy subjects to patients, so we don't want to make too many inferences. But this was designed, again, by one of the architects of Forteo, a very thoughtful person about how to treat this disease, and I think this is a really exciting structure. So stay tuned with Avail. Thanks for the question.
Great, it's so exciting. Can you help me explain to my patients if they wanted to wait for this phase 2 instead of do the AZP trial, and why, how I would explain the difference? And
I'm not taking that one.
Well, I think what I'll say is after we meet with FDA and we have a better idea about what the trial design is going to look like, I think that'll help patients make a better informed decision. I think because it's weekly, the trial design may look a little bit differently. Right now, what we're trying to do is understand how to reduce the touch points for the patients and reduce the burden as much as possible. And I think that's going to be important for patients as they're choosing whether or not to join the study, is whether or not they'll be able to. So I don't know that I can answer that question right now, but I'll say as we understand what the design is going to look like after we speak with FDA, we'll certainly be in touch with the community and we'll be able to help patients understand what that would look like and if it's the right choice for them.
And of course, we hope that those who are able can take part and help, create a really interesting treatment option for patients, hopefully.
Okay, there's a couple online questions. One is a PTH prodrug more biologically compatible than a PTH analog?
Okay, so the active drug, I'm not going to ask my friend in the back to put up that cartoon again. You probably can visualize it, but the active drug is a fatty acylated PTH mimetic, which is, I would say, well, it's in vitro equipotent with PTH, PTH 1 to 84, and quite akin to 1 to 34 teriparatide.
Okay.
Quick question about this technology. Has it been used with other peptides? And is there something you learned from that we might help us to know?
Well, I will say that the same technology is being used across the programs. 2109 is our first and lead indication, so it's sort of paving the way, but we are looking at it in a number of different peptides.
So does this mean that MBX acts more like a natural PTH because it responds to normal activity and stress, kind of acting like the pump does, responding to our needs?
I think the analogy to continuous pump infusion relates to the flat PK profile and just having, quite steady drug exposure, not really, speaking to, modulating that per se by any pump.
And someone wants to know, will you be planning trials in Canada as well?
Yes, yes, I'll just give it a blanket yes. Whether it'll be phase 2 or phase 3, we're working out, but we will have global trials.
And there's one more online question. Will you mandate patients being off of PTH for a long period before starting your trial?
That is something that we're discussing, and again, once we speak with FDA, we'll be able to evaluate that a little bit more. But we've definitely heard the importance of that here today from the patients.
Anything else? Go ahead.
Is it possible to think, not now, maybe in future, about developing such peptide molecule, like prohormone also, but taken orally like tablets? I'll take that one. Like we take thyroxine, which is prohormone.
Well, this is a great question because one of the features of our PEP platform that I did not get a chance to cover in my remarks is that it's fully compatible with non-injectable formulations. And while it's early days, that is something that MBX is exploring for life cycle management.
Anybody else?
Bridget
right here. Bridget? Ooh, I would have to get over here.
A couple of quick questions. Is it going to be like a long-lasting, like longer than 8 hours kind of a drug? And I don't know if I heard right, but will it be pill form or an injection form?
Well, it's a subcutaneous injection with weekly administration.
Anybody else in the room? Okay, well, thank you so much. Great presentation.
Enjoyed it.
And we will be back at 3:15. Welcome back, everybody. And here we are. We're very excited. We have 2 more presentations for today. Our next one, you'll be very familiar with. Deb Murphy is our Director of Research and Studies. She has served the HPA community for many, many years, and she really has taken this on as a passion project for the last year or so. So we're really excited to give her support and hear what she's got today to talk to us about today from RareX. Thanks, Deb.
Well, hello, everyone. Do we need to do exercises to make sure we're all awake? I'm 30 years hypopara, and I'm still alive and kicking. And the reason I am is because I care about our community. I care about what I want to see us improve, and I want to see things happen. I want to also thank you, the HPA board, for allowing me to speak. The reason I got really involved with RareX is because I was blessed to be on that task force with Dr. Manstead and Dr. Schoback, and I was amazed at how much data there really wasn't. And it blew my mind that they had some data that was graded, but most of it was ungraded. So it wasn't really usable data. Now, I know we can't do the medical part of the data or the scientific part of the data, but we can take care of our side of the data. And that's what I'm going to talk to you about today. I'm going to share with you an update on our collection program. Next slide. The speed and productivity of innovation in rare disease is limited by cost and lack of access to standardized and structured data. There's no data. We don't have any data for ourselves. Now, pharma will have their data that they collect from us, and that's fine, but we don't usually get to see it. And NIH has their data, but it's their data. It's like they're put in silos, and they're for their communities, but not for anybody else. And data is not always structured or standardized in standardized form to be used for research in patient communities. Data doesn't always exist. Most groups don't even have the resources to collect their data properly, and that was us. We had no way of keeping or getting our data in one place so that it could be used for research, whatever research needed to be done. And so that's why I started on this quest. I tried several different companies, several different areas to get us going. And most of them required that I would have to put the whole thing together myself. I'm like, I can't do that. So I found this wonderful company called RareX. And RareX is a community that puts the benefit to the patients and the families and the caregivers. It also makes it accessible for researchers to go in and use. So when we put our data in, we are claiming our data as our own. We own our own data rather than giving it to, I hate to say pharmas, but giving it to the pharma because then they have your data, whatever they've gotten from you. This is something that you can put in and you can own yourself. We can also participate in clinical trials. It might make it easier. I can't say for sure. But the biggest one is we will be able to reach researchers worldwide. I don't know if you've heard, like Dr. Manstead talked about the Denmark. Denmark is one of those countries where everybody's got the data. I mean, the government has the data. And that makes it easy for them to do research. But we don't have anything like that. So this is what we're going to do. So far, we started this program in June of last year. And I got 48 people to do it by the end of the year. And as you see, there are 7 countries, 1, 2, 3, I think, in the first half of this, so that's 6 months. Okay? And we've got countries, Australia, Ireland, Germany, Sweden, and Cayman Islands. Wow. This year, we are up to 79 patients. 65 of them are from the United States, but there are 14 other countries that have at least one. The goal of us is to make this a worldwide project. We want to take it so that I have ADH1. I have surgical hypopara. Do we have anything in common? Let's put our data together and see what happens. It may work, it may not. But this just gives researchers a lot more chance to do it. What you would do is you would have to participate and be counted. If you can scan the QR code, anybody on the line, scan it. Moms, scan it and make it so that your children are able to be a part of this. I want everyone to, genetics, surgicals, everyone. It's to help get research going on the ground level. So, I said it'd be short and sweet, and that's what it is. You can scan the QR code. I've got a sign-up sheet right out there. And if you need anything, just give me a call or email. And that's it. Do you have any questions?
Is that the email you just got like last week or something?
No.
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 There's something from the HypoPARA, like a questionnaire.
Oh, there was a survey that was put out by the HypoPARA group. Yes. No, this is separate. And like I said, I have a sign-out sheet out there. I've signed up 14 people this week, which is awesome. And I want to see the numbers grow.
And I think to your point that we do send out different surveys that are sponsored by HPA or the pharma companies or Deb and RareX. It's all about being part of the change, right? There's so many opportunities to be part of the change with the surveys with the different companies. So, but Deb is doing this one, RareX, through HPA.
Yep. All right. Well, thank you very much.
Oh, we got a question.
One that popped up online, sorry. I signed paperwork years ago allowing the HypoPARA Association to follow me, so am I already included in this?
If it was not with RareX, no, and it would have only been from June of last year.
And
Oh, he's got to do it. Okay.
Okay. All right. Any
there's
other questions?
there's one more online now. It says, are there any privacy confidentiality concerns, and can others access the data?
The only people who can access the data, and it's very limited what I can, is me as a PAG, which is I'm in charge. Okay. But I get very limited data, and it's only if you say I can have it. If not, then I don't see the data at all. And when it's sent to researchers, it's always de-identified.
Okay. Very good. All right. Well, thank you so much, Deb. Great job. All right. So we are going to come back for our last session. That'll be at 3:30. We're going to do Ask the Docs panel, and we'll have 4 of our docs up there to ask questions to. So we'll be right back.
Okay, everybody, I'd like to welcome you back to a really exciting session here. We have an Ask the Doc session, so it's going to be open to questions and answers. They're not going to give you a presentation first. They're just going to answer all your unanswered questions from the conference. I'd like to introduce them first. So I have Dr. Mark Warren, Dr. Michaela Rubin, Dr. Lynn Kohlmeyer, and Dr. Michael Manstadt. If we could give them a quick round of applause and thank them for doing this. Do we have any questions from the audience? Anybody from the audience that would like to start us out? Okay, I'm going to start with a question that came in online. If you know you are a stone former and the stones aren't moving or bothering you, is there any need to keep testing?
Keep testing what?
I don't know. That is what all the question says.
Good. Yes, you should continue testing. If you meant the urinary calcium, definitely, or stone profile, because the biggest risk for forming new stones is if you had already a stone. So if you have a stone or had one, you're at way higher risk than the normal population to develop more. So you do want to have a stone profile 24-hour urine. You do want to see a urologist. And with regards to visualization, scanning, ultrasounds, CAT scan, that you want to leave to the urologist who would tell you. Typically, they do at least annual imaging.
Okay.
Can I add to that?
Yep.
I also think it's important to know whether someone's made a stone in the past, because people, believe it or not, forget. Or, oh, it was when they were pregnant, or it was, and if you've been able to make a stone, in my opinion, that's a bad sign. That means likely calcium and oxalate can precipitate into a stone. And then if you already have a stone on imaging, so if you've made one in the distant past, even if it was 20 years ago or more, I'm going to want to look at your kidney with an ultrasound or x-ray. And if you have a stone, it can get bigger. It's kind of a nidus for more calcium to, add on to it. So we absolutely care about that.
I would say in the south where I live, it's the stone belt anyway, so people people have a lot of stones even if without hypopara, so hydrate.
Okay. Are there any recommendations for osteoporosis for hypopara patients?
So we know that hypoparathyroid patients tend to usually have thick bones, kind of the opposite problem of osteoporosis. But there are certainly hypoparathyroid patients who have osteoporosis and thin bones. PTH is interesting in that way because it can actually help bone building. After all, Forteo is an osteoporosis medicine. So you could think that a hypopara patient with osteoporosis would actually benefit from being on a PTH therapy like Forteo. On the other hand, PTH works by kind of moving calcium from the bone into the blood. So there could also be some bone loss with PTH treatment. And that might depend a little bit on the spot in the skeleton you're looking at. PTH might prefer to remove bone from the arms and legs, what we call the cortical bone, more so than the spine or the hip. It might also depend on whether somebody is getting a continuous PTH like TransCon, which theoretically at least might lead to a little bit of more of a decrease in bone as opposed to something like Forteo, which isn't an around-the-clock normal level of PTH. So I think all those things need to be taken into account. Usually I avoid using a medicine which is known as a bisphosphonate like Actonel or Fosamax, or especially a stronger anti-resorptive one called Prolia or denosumab, because those medicines work to kind of lock calcium into the bone, and that could be a real setup for somebody to develop hypocalcemia that could become difficult to treat.
I can add to that. That's excellent. I'm hoping in the future, if we have parathyroid hormone replacement for hypoparathyroidism, not only can you forget about your hypopara, which would be fantastic, if that's the case, then maybe we have a new playing ground where we could treat your osteoporosis as if you didn't have hypoparathyroidism. And I don't know that, but it makes sense.
Michelle, I have a question back here.
Okay.
I have a question. Over the years of having hypopara, I've seen several different endocrinologists, and some of you guys recommend increasing calcitrol over calcium and vice versa. I was just curious your thoughts on that.
Yeah, I'm sure we all have opinions about it, so it's good to have several endocrinologists tell you what they think. Well, first of all, there are sometimes clear rules in medicine, sometimes there is room for different opinions, and I think this is one of these examples, right? And you've heard many talks today and yesterday, they were slightly different, right? You get a little different slant on things. And so historically, the United States were famous for giving a ton of calcium as opposed to calcitriol. In Europe, hypopara patients were treated with much more calcitriol and very little calcium. And so in my opinion, first of all, people should take about 1,000 or 1,200 milligrams of calcium anyway, with or without hypoparathyroidism. And so I target that for hypopara patients too, and often they need a little more, but I rarely go over 600 3 times a day. If somebody is on 2.5 grams of calcium, I want to increase the calcitriol. The flip side, of course, is that one of the few ways of lowering serum phosphate is by calcium binding the phosphate in the food. And so you don't want to decrease the calcium and increase calcitriol in those with high phosphate levels, right? There you need the calcium.
Okay, going back to the question about osteoporosis, someone wants to know if you're already on PTH therapy as you enter menopause, is there extra precautions you need to take to protect your bones?
I think we would certainly advocate for calcium sufficiency, which, would be taking at least 600 milligrams a day, or probably more like 1,200 milligrams a day. I think you'd want to have your bone density monitored. But I think those are the recommendations that I would have for that.
I think to add to that is what we all need to remember, which is to be active, to not fall, to work on your balance, to work on your core. You don't have to have osteoporosis to not think about that. We have to think about that from the beginning. And the more you load your skeleton in a safe way, the more bones you build as you're growing, and then the more you do that, the more you maintain them. Of course, you have to do it safely, and you absolutely don't want to use a trampoline. That might be great for kids, depending on where they fly off, but it takes away the impact. It's dangerous. There's no trampoline recommendations.
Or helicopter skiing.
Otherwise, we want you to be active and love life.
There you go. Michelle, we have one in the audience here.
Okay.
Up front.
Hi, thank you. Hello? Hi, I'm John. As a stone former, hello? Oh, good. Hi, I'm John. As a stone former with high phosphate levels, my endocrinologist is not as informed, and his counsel was drink water. I'm here today. I learned I should increase my calcium and take it with food to bind with the phosphate. So far, so good?
Increase the calcium is not quite right if you decrease the calcitriol. The question was, what is the relationship between calcium and calcitriol that you take, right?
Right.
So if your phosphate is high, I would probably not decrease the calcium amount that you take, but rather the calcitriol.
Okay.
Thank you.
Now, here's the big question. That was my context. The question is, everybody says, take your calcium, perhaps distributed through the day, but always with food. So here's the question. It's actually my wife's question. How much food?
I'm looking at
obesity here.
And I'm sorry that I'm talking again. I had the same question actually just in the break. So it's actually good that you questioned that. My opinion is we're not saying take calcium with food because calcium is better absorbed or it's better for the calcium or for the stomach. It's the other way around. You want to bind the phosphate in the food. So if you have food, take your calcium with that food. It's not like we force you to eat more. No, no. Good, yeah. So if you have 3 main meals, breakfast, lunch, and dinner, right? Take your calcium with these. Because I have patients who come and say, well, I thought I should take it outside of food on purpose. No, no, no. Take it with food because it binds the phosphate. But if you, let's say, you don't have breakfast or very little, and you say, well, somebody told me I should take it with food, so I eat more. No, no, no. Just take it then without food if you don't eat in the morning. But then you don't have, and actually I should leave it like that.
But we do need to know your urine citric acid level and your urine oxalate and what kind of stones you make. And do you add 2 cups of lemonade? Has your urologist, endocrinologist, or nephrologist given you Urocit-K to raise your urine citric acid levels up over 600 to reduce stones? So all that, has a lot to do with your taking your calcium.
Okay, Michelle?
Okay. Can hypopara cause dizziness or lightheadedness when labs are normal, or is this more likely to be related to my thyroid? Who wants that one?
I would say it's more likely related to your thyroid if your TSH is low and your thyroid's high. That's one of the main reasons for that. But you could have low blood pressure. I mean, those kind of symptoms, you need a workup unrelated to your hypopara, and that was one of the messages of several of the talks is, we all tend to understandably blame low and high calcium for everything because it usually is why, but we don't want to miss something else, and so we always need to make sure that we're looking for something else. So you might need an EKG or a Holter or, orthostatics. And
If somebody is on PTH, that does have a small chance of causing dizziness or lightheadedness.
And usually that's within the injection, maybe half an hour after the injection.
Okay, thank you. We have one from the audience.
I'm on the Transcon, but nobody's told me to continue to take calcium just as a daily supplement. Is that something we should be doing on Forteo or Transcon or?
Well, that was my question. And in the trials, they assume, but it's our job to remind our participants that they're still getting 1,000 to 1,200, that's what the protocols say, of dietary calcium. I think that we would be happy with 800 milligrams of dietary calcium because you get a few hundred with vegetables. But what's also really important that's related to your question is to keep taking D3, because if your 25-hydroxy vitamin D level drops anywhere below 20, I mean, usually we want it at least 30, then your parathyroid hormone replacement won't work as well because you can't convert that into 125 dihydroxy vitamin D or active D.
So we should keep track of how much milk or drink and dairy, so that would be part of the 1,000 or 1,200 in your daily? Okay, thank you.
It's almost impossible to get 1,000 milligrams without having some calcium supplement. You've got to eat a fair amount of dairy. So usually most people go around 500, 600 milligrams a day just without any dairy products at all. So, but it's hard to get 1,000.
Especially for those of you who are vegan. So, I've had patients become vegan 2 to 3 years later and kind of forget about their calcium and vitamin D. And so, if you can take fortified orange juice or fortified vegan granola bars, whatever you can find, but you have to look.
For those that are on PTH therapy, though, and if you can't get it from the diet and your calcium is already running at, say, 9.3 to 9.6, where a lot of the Transcon patients are running, would it really be wise to continue taking supplements? Because that might put you
I
over.
think the USRDA, says that we should be taking, at least 600 milligrams a day. So I would recommend that.
All right, Michelle, why don't you do a few questions online, and then we'll go back to the audience.
Okay. Let's see. Should women take extra calcium their entire cycle or more just on the heaviest days?
You have to try it out. You have to test it, right? And I mean, if you do have monthly symptoms of low calcium, and ideally even measured, then you want to take extra calcium during that time. And how much and how long, only you can try and tell.
Okay. I am post-surgical. My PTH is 7 and stays normal. I'm on 1 calcitriol and 1,000 milligrams of calcium, but my phosphorus continues to be high. Are there any recommendations?
The calcium is 7 and...
The PTH is 7, it says.
And the calcium is...
And the calcium is normal. They didn't give an exact number.
And they didn't tell us how much active, we need
Right.
to know how much active D too.
Yes, so you need a lot more information. But the general answer is that taking calcium 3 times a day with meals, or adding calcium with every meal that you're having, without increasing your meals, is a good way of binding some of the phosphate. And then if the phosphate is still high, and if you're not a child, because children have different normal levels of phosphate, then it is a little more difficult. And I typically have a nutrition consult, a nutritionist see the patient, because some phosphate is ubiquitous, it's everywhere, right? It's hard to avoid, but some food have a little more, and it just happens to be the one that I like, so chocolate and nuts. And I also told you the spinach, right? So you can look it up and see what you typically like to eat, and if it's at high of phosphate, you might want to reduce that.
Good answer. Okay. Is there any alternative to calcitriol if it upsets your stomach?
Cricket.
Nobody knows.
Not in the U.S. Canada there is. Yeah.
Okay.
You can take high doses of vitamin D, but it's like 50,000 units a day, and you can quickly get hypervitaminosis, so it's...
Not recommended. Okay. I'm currently in the NAPARA special use program that will stop by the end of 2024. And my endo wants me to switch, but is not sure whether TransCon early access program or Forteo would be a better option. Any suggestions?
I would prefer TransCon over PTH.
I would too. Forteo's too short acting. You have to take it twice a day. It'd be more difficult to get approved. So I think that the TransCon early access program.
Michelle, we're going to take a few in the audience.
Okay.
Hello, my question's a little different. When you have osteoarthritis pain, is it always due to arthritis or can it be due to hypopara?
It can definitely be due to hypopara as well.
But it doesn't have to.
It's hard to know. I mean, that's where you see your doctor, see a rheumatologist, hopefully avoid steroids and prednisone, but do everything else, physical therapy, nonsteroidals if you tolerate them, maybe topical nonsteroidals, all those things that you don't really think might help, but they might, exercise, stretching, and then try to make the difference. I think, my patients in the trials on TransCon and AZP, their arthritis and their fibromyalgia pain went away in days. Now that's, just a few here and there, but it's awfully good to hear. So it's usually a combination.
And it's one of the actually real problems, and that is when you have hypoparathyroidism, it doesn't protect you from having osteoarthritis and osteoarthritis pain. Could it be related? Nobody can really be sure, right? And so how do you decide, oh, this is totally independent of hypopara, it's just my osteoarthritis like many other people have? It's really a big problem. And trying different, for instance, if it's the calcium level, and try different calcium levels. See, does it change with my calcium levels? And if it doesn't, maybe it's not related.
You're up.
So my question is actually kind of piggybacking off of that question. It's kind of funny, we were all thinking the same thing. So I'm only 31, and I recently got diagnosed with osteoarthritis in my shoulders. And so I was wondering, has there been any research, because I know that hypopara patients tend to have thicker bones. Has there been any research into if that contributes towards bone spurs or osteoarthritis.
Well, bone biopsy studies that we've done show that the bone is overly thick and hypermature because it's very slow to undergo the normal bone replacement that healthy bone does. Anecdotally, a number of my hypopara patients do have osteoarthritis, but I'm not aware of studies that specifically looked at manifestations of osteoarthritis.
But now I have like 6 questions, but I'll let. But I do have fibromyalgia, and I saw that it was compounded with the hypopara, but nobody else did, and it was all unrelated, and neither of my doctors would touch it with the other one. Fortunately, I got cancer 3 years ago, and with the chemotherapy, it just seemed to knock it out. The chemo, because it's against the autoimmune, so I had no pain until I started healing, and then it came back. And I went vegan, and that helped the inflammation. So I drink lots of kale smoothies, so I get lots of calcium that way. But someone just brought up the spinach about oxalates, and we need to stay away from oxalates. So spinach, rhubarb, I just looked it up, but a couple of steps. So maybe you could either talk about that or the connection with fibromyalgia, but you've already answered that.
Okay. When and for how long after diagnosis do we need to continue to test our PTH?
Well, the guidelines where most people here have been part of, they say typically if you had hypoparathyroidism for 12 months following surgery, it's likely to be permanent. Now, there are always exceptions, and there are very few patients, some are even published, who recover even later. But so if the hypoparathyroidism has not changed after 12 months, you probably don't need to, you should not expect that it will.
And one of the reasons that kind of came back at us for the trials is you need 2 parathyroid hormone at the same time as a corrected calcium historically in order to qualify for the trials often. And we don't continue to measure parathyroid hormones. So sometimes we have to remeasure it if we can't find that combination.
Is there any research that you know of that shows the percentage of post-surgical hypopara from neck surgery? Like what's the percentage of neck surgeries to hypopara?
Overall, and it really depends on your community, the expertise of your surgeons, whether you have had Graves' disease or a bigger gland, or whether you've had there's so many reasons. Obviously, a more complicated neck surgery is going to increase the chance of hypocalcemia, usually, thankfully, temporary. But I think the number that I remember is 6 to 8% of all anterior neck surgeries ends up in chronic hypopara. Now, when we were in training, and what the surgeons will tell you is that it's less than 2%, and that might be, we hope that's the case at high volume centers. But transient hypocalcemia and hypoparathyroidism can be as common as 20 to 30%, but it doesn't last. So those are the numbers I remember, but I'd love to hear everybody's opinion.
I think, it might be a little bit lower, like on the order of, 2 to 5%, I think, in the hands of experienced surgeons, the permanent hypoparathyroidism.
And I have a question for clinical trials. Dr. Warren, if somebody comes in and wants to be a part of a trial, but they're not in the correct ranges, how do you go about getting people, what do they do? How do we know if people are in the correct ranges for a clinical trial? And then how do you get them there?
It depends on the indications or the inclusion criteria of the trial. And for example, the thyroid function has to be normal in most of these trials, and you have to have the stable dose for 6 weeks prior. And so if they know what their TSH is prior to that, recently, that would be helpful. And if you look on the trial site, you can sort of see what the inclusion criteria are as far as the calcium trial and calcium supplementation requirements are. So that's helpful. And again, if you know what your TSH is before going in, it's helpful. And if it's suppressed, you have to change your dose, and it has to be stable in the AMULET study for at least 6 weeks.
Okay, very
And
good.
in addition, the vitamin D level should be normal, because that takes time to increase if it's too low. And then most trials have, or all trials have, an optimization period, right? Once you sign up, there's time to optimize your numbers such that you qualify to go forward. But typical things that take time is the TSH and the 25-hydroxyvitamin D level.
Some studies require being off a thiazide diuretic for a certain amount of time beforehand also.
And it's such an important question, because if you live far from the site, doesn't mean that you can't still be part of the trial, but you want to try to have your labs as smooth as possible, which is difficult with hypopara. But for the most recent hypopara trial, you want your vitamin D to be over 30, so you might need to up from 2,000 a day to 5,000 or 10,000 for a period of time, but you don't want it to be over 80, you don't want to overtreat. And if you've had thyroid cancer and you've had suppressed TSH on purpose from your endocrinologist, in order for the trials, it has to be at least 0.2 or higher. So that's still 0.4, 0.5 is usually the bottom of the normal range, so you can still have slight hyperthyroidism. And if you've never had thyroid cancer, or you're finished with that suppressive period, and we want your TSH to be normal, we know how hard that is with hypopara and all the calcium. So for this trial, it has to be 0.55 to 7, or 1.5 above the normal range, about 7.5. And then as you're on parathyroid hormone replacement, whatever trial, and your calcium drops, you're going to need less thyroid, a lot less thyroid, because you're absorbing it so much better. And so you really need to watch your TSH every 4 to 6 weeks, as Dr. Dolores Schoback showed us, so that all of a sudden you're not hyperthyroid and didn't realize it. But getting all that done before your first screening day, because then you only have really 2 months. And we don't want you not to be able to be in the trial because we didn't do a good enough job getting things perfect before.
So I think communicating with the study site beforehand and trying to get as much of that done, where we can't tell you what to do before you sign a consent form, but we can tell you it would be a good idea if you work with your doctor about changing your dose. I can't change your dose in the meantime. I can't really tell you anything, except that it would be great if you could work with your doctor and get these things, these labs done.
And working with your doctor is key here, right? Don't change everything just because you think my numbers have to be like this. It has to be supervised by your physician.
Go ahead, Michelle, real quick.
Okay. Why is it that the new drugs we see coming into development don't use the whole PTH molecule? Can you explain why that part of the molecule is not needed?
The question, what's the difference between PTH 1 to 34 and 1 to 84, is the full length versus the fragment that is active, has stirred lots of discussion and some research, and to the day, I have not seen any convincing data that shows us why there is this longer molecule. And for practical reasons, it's much easier. If you know all the activities in the first 34 amino acids, you take this one and modify it instead of having this long peptide.
One advantage of the 1 to 84, the full peptide, was that it did last a little bit longer than Forteo, the 1 to 34. But now that hopefully we're going to have other options that last even longer than the 1 to 84, which maybe lasted like 12 hours, now we'll hopefully have 24-hour long ones with TransCon or the AMULET drug. So I think it kind of obviates that point.
I got a question. It's more about the PTH while on one of these, Napara, one of those medicines. Now, when I was on Napara, I think in the very beginning, and one other time, went up to 11. And at the beginning, it went really high. Now, I'm non-surgical, so no parathyroid glands. Should it happen that when you're on these, whatever medicine it is, the one of the PTH, should your parathyroid go to normal range, or those without the parathyroid glands? Is it typical that we stay low still, even with the medicine?
I mean, when we measure PTH with the blood test in the blood, that's detecting the whole PTH, what we call the 1 to 84. So if you're taking, unless you're taking PTH 1 to 84, which is net para, if you're taking any of these other PTHs, if I understand your question, like Forteo or Transcon, so then your PTH would still be low because the blood test wouldn't be measuring that.
Okay. Someone wants to know, do any of you have any opinion of the new clinical trial that's being run here in the U.S. regarding allotransplantation of parathyroid?
I know that's a study that Dr. Schobach is leading. I don't know if you guys know more about it, but it sounds very promising and very exciting. I don't know the details of it, but I think, the hope is that it could be something like a cure. It does involve transplantation, and I think it does involve some degree of, at least at first, immunosuppression. But it does sound kind of like a potentially exciting new possibility.
Okay. Is there a difference between calcium carbonate and calcium citrate? Which is recommended, or can you mix the two?
It's a good question. There's a lengthy answer to that. So some people, for calcium carbonate to be absorbed, you need acid in the stomach. And if you take medications that suppress acid, like omeprazole, calcium carbonate will typically not be absorbed. So if you're on an antacid, like omeprazole, or you have other reasons why you don't have enough gastric acid, you have to take calcium citrate. And calcium citrate, as I tried to explain, has little, you need more tablets basically for the same amount of calcium than with calcium carbonate. And there was a recent study that seemed to indicate that calcium citrate has less constipation effect than calcium carbonate. It was one study, so it's hard to tell. If you're elderly, then often there's not enough acid in the stomach. And so then you might actually want to have calcium citrate instead of calcium carbonate.
And you can combine them. Yeah. I think what you don't want to do is just take, which I know you don't, any calcium off the shelf that might have a whole bunch of other things in there, because you're taking more than the average person, and you don't want to get too much boron or zinc or whatever marketing, vitamin K, just don't believe any of that. Don't take it, unless we have a study to prove that it's safe and that you need it. Now, we haven't talked about magnesium yet. I know there's a lot of good questions and comments, and you guys can probably teach us more about that. But if there's magnesium in your calcium and you're taking more than one, you don't want to get too much magnesium either, even though you might need some. So that's why for you it matters what calcium you're taking. And you obviously want to tolerate it, and you don't want it to be a big tablet you hate swallowing. So we want to try to find the best calcium for you.
The calcium you hate the least.
Well, all right, we have a question back here.
So I've lately been hearing anecdotal from several people who have been long-term hypopara that they're weaning themselves off their calcitriol and finding that their PTH is coming up. One person that I recently talked to online is like 16 years out like I am, and they are recovering PTH.
So I'd be very careful with that. A lot of people may have partial hypoparathyroidism, which is kind of what I talked about before, and I think that that can still, it doesn't mean mild hypopara. It's almost, it's like being partially pregnant. No, you're hypopara or you're not. You're pregnant or you're not. But I think, I'm guessing that in that situation, if you're able to taper off calcitriol, you've got parathyroid function. I mean, I'm not guessing, that's obvious. So I'd be very careful. I think if your parathyroid hormone was ever less than 10, and your calcium at that time, maybe, I don't know where we would say, let's say it was less than 8.8, I wouldn't try that ever. On the other hand, if your parathyroid hormone, when your calcium's less than 8.5, bounces up to 20, even though you know you're hypopara, then that shows that you have some function. But be very, very careful tapering off of active D without your doctor's guidance.
Within the last 6-ish years? Because I was always undetectable, and now I have like 6, and stuff, so.
Well, the Intech PTH assay's been around probably a good 10 years, I think. So I don't think it's changed the last 5 or 6 years.
When there are different companies,
Yeah.
they use slightly different antibodies, and they have slightly different normal ranges. So maybe the detection limit has changed a little bit, that they can detect something that they were not able to detect before.
And your lab may have been using one assay and they changed to a different assay.
And that reminds me, I don't know if we've mentioned biotin, right? So the assays use biotin to measure these hormones. Everyone needs to be off any biotin supplement, and it can be in something you don't even know it's in, not usually calcium, but a multivitamin for at least 3 to 7 days. I say 3 to 7 days, but before you get your labs done.
Just to qualify this, high dose, these mega doses of biotin. If there's a little bit of biotin in the normal multivitamin, that does not interfere. And even if you're on mega dose of biotin, most PTH assays in this country will not be influenced by it.
But the TSH is.
Thyroid.
TSH, yes. Oh, definitely. TSH, you were talking about PTH, right?
We were, yeah.
We were
Yeah, yeah,
talking
yeah.
about
Oh, TSH is totally different. There you really want to be off of it.
Okay. Do we know if any of the PTH drugs that are being worked on are safe during pregnancy?
We don't. But of course, every pregnant woman has PTH around, right? But it's officially not recommended to take during pregnancy.
So would you recommend or not recommend starting on something like TransCon if you planning on becoming pregnant in the next few years?
Since we are on live microphones and on the ether, the recommendation is not to start it.
I would add that people who are pregnant usually do better with their hypoparathyroidism while they're pregnant. As Dr. Manstad alluded, the body is making PTHRP, which functions almost identically to PTH, and the placenta also makes calcitriol. So actually, for most women, of course, there are exceptions. Pregnancy is a time where the hypoparathyroidism becomes much more mild. And obviously, it's very important to be closely monitored by the doctor because the baby will be affected by the calcium level. So if the mom's calcium level is too low, the baby can have hyperparathyroidism, or the opposite scenario could also happen.
All right. Well, thank you so much for all 4 of you participating and sitting in the hot seat up there. I wanted, before we close, is there anything else you'd like to say to the group before?
I'd like to say a couple things. I want to thank everybody. First of all, this has been an amazing opportunity and experience for us, and I've learned so much. There are some medicines, and maybe we can add to this, that you shouldn't take if you have hypoparathyroidism, and we haven't brought it up yet. And one of them is Wellbutrin. It's a great medication. I've never prescribed it. I'm an endocrinologist, but it's for anxiety and depression. But it has a low seizure threshold. It lowers seizure threshold. And so if you are hypoparathyroid and your calcium might drop, you don't want to be on Wellbutrin. So I just wanted to make sure we all knew that. And there are other medicines that lower calcium, and you mentioned bisphosphonates, but I think that that's important to know.
And I would echo, it's a great meeting. I appreciate the invitation to be here. Be patient. We have treatments are coming.
Very good. All right.
Well, thank you all very much.
Thank you. All right. All right, so Michelle and I are going to close things out here for today, and really thank you all for participating and all the knowledge that you've shared with us. So
Oh, I guess I can use this now, right? Okay. So really, we just want to close things up with really, I talked to you a little bit about everything that we did this past year and things that we're going to be doing moving forward. But I do want to take another second to really recognize this one right here, because she has put her heart and soul into this organization this last year, and that website that we have is just amazing, and I want her to talk just a little bit more about it, and the PFDD coming up. So take it away.
Thank you. So if you haven't checked out our new website, I'm hoping everyone in here, that's how you found out about this event. But I encourage you not just to look at it for events or the homepage. We have a lot of new great resources that I've done a lot of work on our new website. So explore around. Don't be afraid to click, and don't be afraid to ever email me and ask where you can find something if you're having difficulty, because that's the only way we're going to know how to make the website better or easier to navigate. We have some great new resources on there. We've partnered with some new foundations. One of them is the Patient Advocate Fund, and they help you find resources for getting your drugs paid for, resources for fighting with your insurance, different things like that. We've also partnered with a company called Aimed Alliance, which has written a wonderful pamphlet that's on our website about explaining to you what some of the terms you might see from your insurance company, especially when a new drug comes on the market like TransCon PTH. You're going to see words like prior authorization, step therapy, different things like that. I encourage you to learn about those things before the time comes, and then you're so overwhelmed and frustrated and you don't know what the next steps are. I really encourage you to explore those items and then reach out to the association. We might not have all the answers, but we're certainly willing to help you find the answers, okay? So I want to encourage that and explore. And if you have a really great endocrinologist, please go on the website and recommend them. We have a new map that shows where those endocrinologists are. We've been getting some recommendations for other countries, so all those people watching online, please, if you're in another country, recommend your endocrinologist if you have one, so that your fellow hypopara warriors can find that same person. So that's a little bit about the website, and I'd be happy to talk to anybody afterwards about if you have more specific questions about it. But my passion for the next year is to encourage you to be a part of the change you want to see in the hypopara world. And part of being that change is advocating for yourself, that's obvious, but we're going to have a lot of things you're going to see in this next year, where I'm going to ask of you to share your testimony and help us make a difference for more than the 1,900 of you that follow us on a regular basis, okay? So things like the PFDD, and some of you may or may not have seen my previous video about what is a PFDD. I'm not going to go into the whole video, but I will share a little bit. It stands for patient-focused drug development. Thank you all, I lost my wording. Patient-focused drug development. It is a really big meeting. We started working on the application last year. We turned in the application in February. We went through all the things and finally got our approval to have the meeting sometime around April. And our meeting date has been set for March 5th of 2024. I am excited to tell you that we have to have 2 panels, and we have selected those panelists. Some of them are in the room. Raise your hand if you don't mind being recognized. We have some panelists in the room, and we're super excited for them. But on top of that, we still need the rest of you to join in this fight. And maybe you don't understand the purpose of what we're trying to achieve with the PFDD. There's a lot of things we're trying to achieve, but one of the big focuses is we want the FDA, as well as researchers and other people that will read the paper that will come out of this, to understand that this is not a hypocalcemia problem. This is an endocrine problem. And until they start to see this as an endocrine problem, they're not going to want to pay for treatments that treat an endocrine problem. And so we're going to need your help to make that, our focus, and to make them hear our voices. So one way that you can help is look at when that meeting is and plan on being there, whether it be virtual, because it will be live streamed with my good friend John over here. He's going to help us again. And it will also have an opportunity if you live in the Washington, D.C. area. It is going to be in Maryland, but it is close to Washington, D.C., about 25 minutes outside of the downtown D.C. area. So anybody that lives in this area, I would encourage you to come and attend the meeting in person, because they will listen to you. There will be an opportunity for people to speak and answer questions. So I really, really want to encourage that. But mostly, I really, really want to encourage you to do what you can, whether it be give 1 hour a month to the HPA organization, or just simply send me an email with suggestions, because it is helpful. It gets tiring to be the only one to come up with ideas. So I'm not saying that the rest of the board doesn't. I mean, the board, we're small. For those of you that don't know, the board is only 6 people. We do all of this with the power of 6. And we each have things that we specialize in, and we can definitely use your help. But change is not going to happen for our greater community if we don't all participate. And with that, I'm going to leave it at that.
All right. Well, thank you, Michelle. All right, guys. So here we are. We are at the end, but I did want to also recognize, could I have my board stand up? I have Deb Murphy. Thank you so much. Stand up and remain standing. I have Loretta Gully back there, who's done a fabulous job as our secretary. I have Bob Sanders over there serving as our president. And I would like to ask anybody that's in the room that's a caregiver, if you guys could please stand and remain standing. Thank you for being here today. If I could ask anybody in our medical community that is here to support us, if you could please stand and remain standing. Our medical advisors, our physicians, our doctors, our pharma, everybody up. And then if I could have our patients please stand. All right? Look at this room. It takes all of us to be part of the change. And for you guys online, stand up in your seat and be a part of the change. Thank you, everybody, for being here. Have a wonderful rest of the day, and we'll talk to you soon. Thank you.